We're going to move on to cardiovascular, very easy topic on the exam. They really decrease the amount of questions on the exam, so it is pretty easy. So let's start with cardiovascular part 1. And here we go. 20%. Used to be 32. So on the new exam now, they knocked it down to 20%, piece of cake. You're going to see 30 itty-bitty baby questions. You won't have any problem with cardiovascular whatsoever. So let us start. Hypertensive crisis. Always a question on hypertensive crisis. Now, there's 3 different kinds of hypertensive crisis. There's essential hypertension. There is accelerated hypertension. And then there is malignant hypertension. On the exam, they ask you about malignant hypertension. Just for your own information, accelerated hypertension is a diastolic that is greater than 120. And it's associated with retinal hemorrhages. Now, malignant hypertension, which is on the exam, is a diastolic blood pressure greater than 140. Not 140, but greater than 140. So if you have a blood pressure 240 over 142, that is malignant hypertension. So malignant hypertension, a diastolic greater than 140. And it's associated with retinal hemorrhages and papilledema. The treatment, just for your own information, would be vasodilators and sympathetic blocking agents. But what you have to know for the exam is the diastolic number with malignant hypertension, and you know that it's greater than 140. Good, learning has occurred. One question down, cardiomyopathy. Always questions on cardiomyopathy. Now, there's 3 kinds of cardiomyopathy. There's dilated cardiomyopathy, which responds very nicely to digoxin. There's hypertrophic cardiomyopathy, which is what they ask you on the exam. And then there's restrictive cardiomyopathy. On the exam, they ask you about hypertrophic cardiomyopathy. Now, hypertrophic cardiomyopathy, HCM, is the same thing as hypertrophic obstructive cardiomyopathy, HOCM, which is the same thing as idiopathic hypertrophic subaortic stenosis, IHSS. So HCM, HOCM, and IHSS are all the same thing. So idiopathic hypertrophic subaortic stenosis is the same thing as hypertrophic obstructive cardiomyopathy, which is the same thing as hypertrophic cardiomyopathy. And so what is this? A fat septum. That's what it is. You got yourself a really big fat septum, and your big fat septum hangs out into your left ventricle. So rather than your left ventricle filling up with 70 cc's, it only fills up with 30. Why? Your big fat ventricular septum is hanging into your left ventricle. So you have a decrease in cardiac output. That's it. So you can't go to a doctor and say, listen, I don't feel good anymore. I have no energy, I'm weak, I come upstairs, I get short of breath, I think I have palpitations, I feel like I'm dying. He can't say to you, you got a fat septum, give me $750. You wouldn't give him any money. Whereas if he says to you, while you have idiopathic hypertrophic subaortic stenosis, you're thinking he's the smartest doctor in the world. So IHSS, HOCM, and HCM, what is it? A big fat ventricular septum that hangs out into your left ventricle. That's easy. Here, I'll give you the real medical definition. Increased thickening of the heart muscle and septum. It's primarily the septum. Okay. Inwardly, at the expense of the left ventricular chamber. Thus, the ventricles will become rigid and stiff, and the restricting the filling, and the stroke volume will decrease, and the cardiac output decreases. Because rather than filling up with 70 cc's, you only fill up with 30. So you have a decrease in cardiac output. Now, on the exam, it says your patient has just been diagnosed with idiopathic hypertrophic subaortic stenosis. You, the nurse, knows that this results in a decrease in cardiac output. Which of the following pharmacological modalities, drugs, should be given to your patient to improve the cardiac output? Answer choice A is digoxin, and it's wrong. Can't give them digoxin. Not a good thing. You can't give somebody that only has 30 cc's in their left ventricle, you can't give them an inotropic drug. You can't give them dig, because you don't want to take the 30 cc's that little bit of blood and squeeze it out really quick, right? You don't want to take a little bit of blood and go, because all the cells in the body are like, hey, 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 did you see it? I think something went by here. Did you see anything go by here? So you can't give DIG. You don't want that. Matter of fact, you don't want DIG. You don't want dobutamine. You don't want dopamine. You don't want anything that improves myocardial contractility. You do not give to these people because you don't want to take the little bit of blood and squeeze it out really, really quick. But you have to give the negative inotropic drug. A negative inotropic drug, like a beta blocker you have to give. The best ones are verapamil and Inderal. Those are the best ones. Because see, if I give you a beta blocker, if I give you verapamil or Inderal, I give you a beta blocker, or calcium channel blocker, I'm sorry, and a beta blocker. If I give you anything that decreases your myocardial contractility, it's going to slow down your heart as well. So if I give you Inderal and it slows down your heart, rather than filling up with 30 cc's, you'll fill up with 35 cc's. And then, since it's a negative inotropic drug, it'll take this little bit of blood and squeeze it out a long way. Right? Rather than sit, taking the test, look at your friend and go, right? So she knows you're up to that question. Or you look at it and go like this. Remember yesterday, otal carcinoma, viral pneumonia, head problem. And then you're going to stand up, and what are you going to say? I'll take the large bowel. Very good, learning has occurred. So, getting back to IHSS, HOCM, or HCM, you got to give a beta blocker or a calcium channel blocker. Why? Because it decreases myocardial contractility. Because you want to take that little bit of blood and squeeze it out a long way. Digoxin is contraindicated. Digoxin, isopril, dopamine, dobutamine, anything that improves myocardial contractility is contraindicated. Also, anything that vasodilates is contraindicated. You know, because these people, sometimes they come into the hospital with chest pain. And you give them nitro, and what happens is their eyeballs go behind their head. And then someone puts a sign over the stretcher, sensitive to nitrates. So I take down the sign and say, get me out of here, they're killing me. No. You don't want to give anything that vasodilates. Because see, if your left ventricle only has 30 cc's, by giving you nitrates or morphine or anything that vasodilates, I'm pooling blood in the periphery. So rather than your left ventricle filling up with 30 cc's, it only fills up with 10. And then you have no cardiac output and your eyeballs go behind your head. So nothing that improves myocardial contractility, nothing that vasodilates. That is all contraindicated. So what do you think? That's easy. So now it's 3 questions you're going to get right. Good. Here's another topic. Oh, what topic is this? Swan-Ganz. Very good, very good. Okay, let's say a few words about Swan-Ganz catheters. I mean, it's been rather recently that swans haven't been used that much, but now it's on the upswing. It's on the upswing now. And so it's reflected on the exam. You know, when you have a pulmonary artery catheter, Swan-Ganz catheter, it's advanced into your right atrium, it's further advanced into your right ventricle, and then it's further advanced into your pulmonary artery. When the catheter sits in your pulmonary artery, you're going to get 2 values. You're going to get a systolic number, and you're going to get a diastolic number. You're going to get a pulmonary artery pressure comprised of the top and the bottom number. The top number is the systolic number. So the pulmonary artery systolic number. And that number is higher than the PAD, the pulmonary artery diastolic number. Now the systolic number is the number you get when the right ventricle is squeezing the blood out into the pulmonary artery. Whatever pressure is generated, that's your PAS, that's the top number. So if you've got a lung problem, the PAS is elevated. Because you see, when you have a lung problem, no matter what kind of lung problem it is, whether it be hypoxia, COPD, pulmonary embolism, ARDS, no matter what pulmonary problem you have, it always results in pulmonary vasoconstriction. And if your capillary beds in your lungs are all vasoconstricted, when the right ventricle goes to squeeze the blood out into the pulmonary artery, into the lungs, if your lungs are all vasoconstricted, there's going to be an increased pressure generated in the pulmonary artery because the blood has a hard time going into all those vasoconstricted capillary beds in the lung. So that if you have a lung problem, when the right ventricle's in systole, there's some increased pressure generated in the pulmonary artery as the blood is trying to go into those very narrow lumens of the capillary beds. So if you have a lung problem, the PAS is elevated. Any lung problem, the PAS will be elevated. So again, whether it be pulmonary hypertension, pulmonary hypoxia, ARDS, COPD, pulmonary embolism, whatever lung problem you have, it results in pulmonary vasoconstriction. And that's why your PAS will be elevated. Now the PAD is a number that is recorded when the pulmonic valve is closed. During diastole, your pulmonic valve is closed. And if your pulmonic valve is closed, you have your pulmonary artery and then you have your lungs. So that when the pulmonic valve is closed, do it like this. When the pulmonic valve is closed, the aortic valve is closed as well. And during diastole, of course, the PAD, during diastole, the mitral valve is open. And what happens is this tip of the catheter is not only hanging out in the pulmonary artery, but since the mitral valve is open, it not only looks into the lungs, but it can also see into the left atrium as well as looking into the left ventricle. So that's why they say that your PAD is pretty much reflective of your left ventricular and diastolic pressure. That is the pressure in the left ventricle at the end of diastole. So the PAD is the catheter sitting in the pulmonary artery, looking at the lungs and looking at the left atrium, and then in diastole, your mitral valve is open, so the tip of the catheter can really check out the left side of the heart. That's why whenever you got a heart problem, your PAD is elevated. Whenever you have a heart problem, your PAD is elevated. Because the PAD generally, or usually, key word here is usually, looks at the left side of the heart. And the PAD will be elevated anytime you have a heart problem, whether it be cardiac tamponade, failure, overload, mitral valve disease. If you got a heart problem, the PAD is elevated. That make sense at this hour of the morning? Okay, good. That's why a lot of physicians will tell you, don't wedge the catheter, just look at the PAD. Just look at the PAD, because they know that the PAD is usually, keyword usually, reflective of the pressure on the left side of the heart. So if you have a lung problem, your PAS is elevated. If you have a heart problem, your PAD is elevated. Good. Now the normal pulmonary artery pressure, the systolic number is 20 to 30. And it changes depending on what book you read, but that's within the usual range, 20 to 30. And your PAS, being 20 to 30, will be elevated if you have a lung problem. Now your PAD is 6 to 12. Some books say 8 to 14. I like 6 to 12. So the PAD, that's the pressure you get during diastole when the pulmonic valve is closed and the catheter is just hanging out in the pulmonary artery, looking at the lungs and looking at the left atrium, and then since the mitral valve is open, it's checking out the left ventricle. And your PAD is 6 to 12, but that would be elevated when you have a heart problem. Good. Now, your PAD closely corresponds to the left ventricular and diastolic pressure. That is the pressure in the ventricle at the end of diastole, except in certain conditions. So there are certain situations you cannot use the PAD to tell you what's happening to the left side of the heart. On the exam, you don't have to know the particular conditions. For the exam, you just have to know that the PAD is not always an accurate indicator of the left ventricular and diastolic pressure. For the exam, you have to know that you can't always use the PAD to tell you what's happening on the left side of the heart. That it is always, it's not accurate always. That's what you have to know for the exam. So the way the question's set up, they have a question, and then they got one statement, two, another statement, three, another statement, four, another statement, and then A is statement 1 and 2 are true, statement 3 and 4 are true. So the thing you have to know is that the PAD is not always an accurate reflection of the left ventricular and diastolic pressure. But you should know for clinical practice when you can use the PAD and when you can't. right? You can't always use the PAD. It's not always accurate. So to give an example, I got floated to open heart, and they just hired 3 new open heart surgeons in addition to the ones they have. And I heard that one of them has a real, behavioral problem or whatever. He's got a bad temper, he curses, he throws things, And, and the nurses in open heart are complaining. I mean, personally, if I was in a unit and a physician threw something, I would call the cops so fast, this guy wouldn't know what to hit him. Who ever heard of such a thing, throwing things? I mean, what if housekeeping came in and started throwing mops and brooms? You'd have the guy arrested. But because the guy's an open heart surgeon, you're like, don't do anything about it, and I never heard of such a thing. Anyway, so everyone's all complaining, blah, blah, blah. I get floated up there. And it's like 2 o'clock in the morning, and he comes in. And they all run and go in the utility room. I'm like, what happened? What happened? So he goes over, and he goes over to my patient, looking at the clipboard, takes the clipboard and starts hitting it on the nurse's station. But violently, like violently like that. So I walk over, I'm like, can you stop this behavior? Because what I'm going to do is I'll call security. And not only security, I will call the cops on you, and I will have you arrested for assault. All right? You didn't hit me yet. Because then I have you arrested for battery. But I bet I could press some buttons where you would hit me. Anyway, so I said, stop the behavior right now. Go home, check your lithium levels. Will you please? This behavior is totally inappropriate. Then I'm thinking people will come out of the utility room to help me out. Hey! So anyway, he's having a fit, and his big temper tantrum is because I wedged the swan. He said, you shouldn't, I don't want my swans wedged. I don't know why you wedge a swan. You're not supposed to wedge a swan. I said, well, I looked through the chart. There's no order from you saying that I shouldn't wedge the swan. Okay? Case closed. Well, you should know. I said, listen, I wedged the swan because your patient has mitral stenosis. And whenever you have mitral stenosis, the PAD is not accurate. Because you see, whenever you have mitral stenosis, it means that your mitral valve is very, very stiff. And when you have a very, very stiff mitral valve, very stiff, it don't open good. And if it don't open good, the blood in the left atrium has a real hard time being squeezed down into the left ventricle. Why? Because your mitral valve is stiff and it don't open good. Thus, that increased pressure generated in the left atrium is picked up by the tip of the catheter. Thus, when you're looking at the PAD, you're really looking at the pressure in the left atrium rather than measuring the pressure in the left ventricle. That's why I wedged this one. Okay, case closed. Then he wants to know, what's your name? What's your name? What's your name? So I'll tell you my name. What are you going to do? Get me fired? Make my day, all right? Make my day. Get me fired. You know what I'll do? Matter of fact, if you get me fired, I'm pretty much retired from business, but maybe I'll start it up. You got 52 full-time nurses here in this open heart unit. I think I'll open up my own open heart nursing agency. I'll pay them $125 an hour. They'll all leave here and come work for me. Then you would have to sign on the dotted line to have these nurses back. Because see, if you don't have open heart nurses, you can't do open heart surgery. Like, what are you going to do? Pull from L&D? So I'll be paying them $125 and I'll be billing you $175, all right? Make my day. Here's my name. And then I said, get out of here, scat, will you? Check your lithium levels. And then I told him, I said, when I was coming in at 7 o'clock, I saw you in the parking lot. I didn't know who you were, but I saw you in the parking lot. I happened to notice you because you were with a day babe, a blonde. I got a feeling you went somewhere with her, and you needed like some kind of alibi for your wife, and that's why you popped up here at 2 o'clock in the morning. I took pictures. And then everyone comes out of the utility room like, oh my God. Yeah, I can't believe it, I can't. Where were you? I'm starting to open heart nursing agency, I'm doing this, and you're all in there. A bunch of afraid of their own shadow. All right, anyway. Really, if you're ever looking for a group of easily intimidated people, find some cluster of RNs somewhere. Can we have some nurses that want to kick a little butt out there? I mean, really, we need people to stand up and talk back and say, your behavior is totally inappropriate. Or they asked me to float to New York. How would you like a challenge? I said, challenge? I'm 60 years old. I'm lucky I get out of bed. What do you got in mind? How would you like to go to neonatal ICU? Neonatal ICU? I've been an adult critical care nurse for 40 years. You want to put me in neonatal ICU? What drug are you taking today to think I can work in neonatal ICU? She said, well, everything's the same. It's just smaller. It's not smaller, you moron. You got different medications, you got different pumps, you got different ventilators. I don't even know what your pulse is supposed to be when you're born 3 months too early. What's your pulse supposed to be? I don't know. Do you know it? I don't have an idea. And where do you take a blood pressure? How do you take a blood pressure? I don't think they put a little cuff on their arm. I don't think. I don't know. What do I know? Yeah, a challenge. What would this be? A challenge of killing little kids? Get out of here. Go play with your timesheet. Stop walking around this place, will you? You know, and then everybody's like, oh my God, I can't believe he said that. I can't believe. I was like, you know, where are the big mouths in this profession? Where are they? You know what it is? You got them? You got some big mouths here? That's what we need. You know, the problem is you get mentally mutilated in nursing school. No, as a tenured professor for 12 years, I saw it happen. Nursing students, you get mentally mutilated. It's just a real sin. You know, I did several dissertations that always got rejected. It took me 10 years to get my PhD. And then one year I decided to suck up and just give them whatever they wanted. But anyway, one of my dissertations, I compared nursing schools to medical schools. Because I wanted to understand what goes on when normal people go into nursing school and then when they get out, they become mentally mutilated. Like what happens, you know? So what I did is I sat in on medical schools for a few weeks, 6 of them, and I sat in on nursing schools. Just like one day. 6 of them, you know. And it's interesting, with the medical schools, most of the classrooms are set up like amphitheaters where the professor's down there and the students are, you know, up there, you know. And, you know, first day of medical school, the professor greets you at the door, he's shaking your hand, welcome, welcome. And in 2 of the 6 schools, they said doctor. These kids weren't even shaving yet. They're like, welcome, doctor. You know, and as they were walking in, the heads were going boop, 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 boop. And then during lecture, it was like, you will become physicians. People will look up to you. They will respect you. And right before your eyes, you saw the heads going boop, 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 boop. And then like the 3rd day of medical school, they have a big ceremony where they present you with your white lab coat and all your family comes and everything. And it's like big to do. And, you know, everyone gets down on their knees while they give you the white jacket, you know. It's a big to do. It's all catered, you know, bah, bah, bah. Okay. So after, you know, a few weeks of that, these medical students came in, they had a head like this and then wound up being like this. Okay, so then I sat in on nursing schools. And like the first day of nursing school, it's always done like in a college, you know, where you're sitting at a desk and everything, and then you got some old wench, like untouched by human hands, man or woman. And she's like, she's up at the top at the desk, you know, and she's really cranky, she's not smiling. And you all come in and you're all positive and happy and like, oh, you know, you're like that. And this is like annoying the hell out of her because, you know, she hates happy people, okay? And then she decides to give you the look. She's giving you the look because you're talking in her classroom, all right? Anyway, she's giving you the look. And then you catch on, maybe shouldn't be talking, so you'll sit down, you're like this one, all right? And then she stands up, she's like, look around you, because only half of you are going to pass, you know? So all of a sudden, your head goes there. Yeah. By next Tuesday, I want you to read 155 pages in your Luckman and Sorensen. And I'm going to give you a test, and don't think you're going to get an A. It counts for 30% of your marks. And by next Tuesday, you want 6 care plans. They have to be typewritten and your turbulent style and beat the thing. But I tell you, after the first day, the nursing students were in the hallway. They were in a fetal position. They were urinating on themselves. And this is when it all happens. It's a sad thing. But anyway, let me just explain to you. So the moral story is, I need people in this profession with a big mouth and a bad attitude, okay? Don't be afraid. Don't be afraid. And people say, well, what if I get fired? You know, I worked in a hospital where they fired the nurse manager of the ER, and she was in there 17 years as the nurse manager of the emergency room. The greatest nurse you ever met in your entire life, all right? Matter of fact, she's nurse manager for 17 years, but she was nurse for like 20-something years before that. Excellent nurse. Well, they got a new medical director of the ER or whatever, and he didn't like her. Why? She was smarter than him, that's why. Anyway, so on Friday, they got rid of her. And so what happened is all the phone calls started, and I told people, if you go in, I'll have you killed, okay? Well, I'll have someone to kill you. You will die, okay? Do not go in. You're not going into work. Nobody's going into work. And no one went into work. No one went in. No one went in. You try to run an ER without nurses. What are you going to do? Pull from L&D? And you know you ain't going to get no critical care nurses going down there, because if anyone has a mouth, critical care nurses, you know, have somewhat of a mouth, you know. So there are no nurses when Saturday, Sunday, Monday, Tuesday. they hired Barbara back because, you can't run an ER without nurses, and then our request was to get rid of him. And it worked. It's just sad that you don't read about this in your professional nursing journal. So you do stick together. Don't be afraid about getting fired, because if you do go on the limb and you do get fired, hopefully your colleagues will stick with you, and you all just stay and hang out at her house until you get the call from the hospital, right? Here we go. So the PAD closely corresponds to the left ventricular end diastolic pressure, and except in certain conditions. Let me just tell you what they are. Just in clinical practice, it's good. If someone has a right bundle branch block, you can't use the PAD. Because if you have a right bundle branch block, there is a delay in right ventricular systole. And that delay in right ventricular systole causes a delay in blood going into the pulmonary artery. That when you have a right bundle branch block, that delay in right ventricular systole causes a delay in the blood coming out of the right ventricle. Thus, that delay in right ventricular systole will cause a drop in pressure in the pulmonary artery. Why? Because no blood came out of your right ventricle yet. And it leaves more time for the blood that's in there to trickle over to the left side. Thus, when you have a right bundle branch block, the tip of the catheter is really reflecting the drop in pressure in the pulmonary artery rather than telling you what's happening on the left side of the heart. So when you have a right bundle branch block, can't use the PAD. When you have mitral valve problems, whether it be mitral stenosis, as I had explained, or mitral insufficiency, you can't use the PAD. Because, see, when you have mitral insufficiency, you have yourself a mitral valve that just don't close good. I hear my husband in my head saying, Laura, that's improper English. It's the mitral valve does not close well. We're complete opposites, all right? I'm like a truck driver. I have a vocabulary of 100 words. I'm sure 50 of them profanities. And he's Mr. Lazarus, or whatever you call that book. Anyway, so when you have mitral insufficiency, the mitral valve does not close good. Well, it's well, Laura, it's well. The kids that come home from school, I'm like, how'd you do? Did everyone do good today? How'd you do? How'd you do? You do good in school? You do good? He's like, Laura, it's, did you do well in school? Children, did you do well in school? I'm like, it's good. How'd you do? You do good? I'm like, it's not well, it's good. Did you do good in school? Good, bad, well, sick. There's a point. When I had my foster kids and then my kids were born, I had like 9 kids, I had 3 babies, and so, and I had help in the day, but I forgot to get help in the night. I don't know what happened. But anyway, I was cracking. I was really cracking. I didn't sleep for a year because my babies had to be fed every 2 hours, and they took like an hour to eat, so I was just feeding them 24 hours a day. And then Jeffrey was 6 months at the time, and so I had to feed him, every 4 hours, so I didn't sleep for a year. So I decided I just hated my husband. I don't know, I just hated him. I hated the way he was breathing, looking, I couldn't stand him. No, because I was in my pajamas for a year, and he would get dressed and go out and go to work for 8-10 hours. Hey, I'll switch any day, So anyway, I got to a point where I couldn't stand him. All right, so then, someone said, oh, you got to go counseling. I'm like, okay, I'll try. So we went to counseling, and then they told us, oh, well, you just have to make time for yourself. So every Thursday you go out on a date. I'm like, all right, I'll go out on a date. All right, so I got dressed up. I thought I looked pretty good. I had black pants on. I had like a leopard top that had a V-neck. I thought I was looking pretty good for women my age and 9 kids, okay? All right. So I come out of the bedroom, and he says to me, you're looking very meretricious tonight. So I don't know what meretricious means, but it sounds like a good word. It has the word merit in it. It sounds like a good word. And I'm so tired of saying what, huh, and then looking it up. I'm looking like a jerk in front of these kids. So he says, we're looking very meretricious tonight. And I was like, thank you, Charles. Because his name is Charles, and don't even think about calling him Chucky or Charlie or something. I'm like, thank you, Charles. So then we go out, and then we come home. It's 9:30. And then, of course, he makes the big announcement. He has to go to bed. He must retire. That means go to bed. Because he has to go to work in the morning. Oh, I don't go to work. I got 9 kids, 3 babies. I'm running at that time. I had 2 companies. But I don't have a job, all right? So anyway, big thing. I got to go. All right, go to bed. So now it's 9:30. I say to myself, okay, I got 1 million kids. I got to make sure I have at least, 24 bottles for tomorrow. I got to make sure I have at least 36 diapers. And then I got, Stevens in pre-K, kindergarten, first grade, second grade, third grade, fourth grade. So then I got to, make them all their lunches, and I got to make them all their healthy snacks, and I got to do 4 loads of laundry because you can't miss a day of laundry, all right? Then I got to think about dinner. God forbid Charles eats chicken nuggets and macaroni and cheese, so then I got to think what I'm going to make for him and this, and then I'm doing laundry, and I got the kids propped up. I got one baby I'm feeding over here. The other 2 are propped up. I'm vacuuming. I'm folding in between, and it's like 1:30 in the morning. I'm like, whose brainstorm was this to go out on a date? I could have had like a lot of this stuff done already. So now I'm mad. So then I go to the computer just to look up the word meretricious. Whore. Whore, slut-like in appearance. I woke him up. Yeah, I woke him up. And my husband doesn't like, he doesn't like anyone touching him when he's sleeping, else he can't sleep. You know what? I don't know what the hell his problem is. Anyway, you can't touch him when he's sleeping because then he can't sleep. Who could figure this out? Anyway, so that's why he doesn't like all the kids in the bed because, kids are all over you and he can't be touched when he's sleeping. I don't know what his problem is. But anyway, but it's changed because ever since that night, we've now had, at that time when I had to force the kids, we were all in the bed. That's it. I woke them all up. I'm like, hurry up, get up. Come on. We're going in bed with Daddy. He wants to sleep. We're going in bed with Daddy. I had like 3 babies and 7 kids. It was so... But every time I talk, I hear him in the background. It's like, Laura, the valve does not open well. But anyway, whenever you have mitral insufficiency, your mitral valve just don't open good. And when you have mitral insufficiency, you have a mitral valve that just don't close good. And because it don't close good, blood goes backwards through it. Whenever you have mitral insufficiency, when the left ventricle is in systole, blood will go backwards, right? It goes backwards through the incompetent closed mitral valve into the left atrium. And when blood is backing up into the left atrium, because you have mitral insufficiency, the tip of the catheter picks that up rather than telling you what's happening in the left ventricle. So whenever you have mitral insufficiency, mitral stenosis, right bundle branch block, can't use the PAD. When you have decreased left ventricular compliance, you can't use the PAD. Because if I have decreased left ventricular compliance, I have myself a very stiff left ventricle. And if my left ventricle is very, very stiff, when the left atrium goes to put the blood into this left ventricle, which is very stiff, there's an increased pressure generated in the left atrium because the left atrium is having a hard time squeezing the blood down into the left ventricle. So what happens is this increased pressure generated in the left atrium is picked up by the tip of the catheter. Thus, whenever you have decreased left ventricular compliance, you can't use the PAD because it's really going to just tell you the pressure in the left atrium. Whenever you have pulmonic insufficiency, you can't use the PAD. Because if I have pulmonic insufficiency, I have myself a pulmonic valve that just don't close good. And if it doesn't close good, the blood goes backwards through it. When you have pulmonic insufficiency, the blood leaves the pulmonary artery and goes into the right ventricle. Thus, there's a drop in pressure in the pulmonary artery. Thus, the tip of the catheter picks up on that drop in pressure. So it's not really telling you what's happening in the left ventricle. Whenever you have aortic insufficiency, you can't use the PAD. Because when you have aortic insufficiency, you have an aortic valve that just don't close good. If it don't close good, blood goes backwards. When you have aortic insufficiency, blood goes backwards. It goes backwards up into the left ventricle. Now, when the mitral valve sees all this blood going backwards, the mitral valve will shut prematurely. Boom. Now, when the mitral valve shuts prematurely, the tip of the catheter is really looking at the left atrium rather than telling you what's happening in the left ventricle. So, whenever you have certain conditions, you cannot use the PAD. So whenever you have right bundle branch block, mitral valve disease, pulmonary hypertension, decreased left ventricular compliance, aortic or pulmonic insufficiency, you cannot use the PAD. But for the exam, you just have to know that the PAD is not always an accurate indicator of the left ventricular end diastolic pressure. That is not always accurate. That's what you have to know for the exam. So that's easy. Here we go. There's a pulmonary artery pressure. And you notice when you're looking at a pulmonary artery pressure, you should get, some mountains going along. That's a good thing. right? When the baseline is wavy, that's a good thing. Why? It means the patient's breathing. That's what it means. You notice whenever you take a deep breath in, the waveform will be pulled down. So that's a good thing. And you just got to remember that you have to take a reading, whether it be the wedge or whatever reading you take, always must be before the dip. You always should take the reading at the end of exhalation, which is right before you inspire. Therefore, it's right before the dip. So whenever you do take a reading with the Swan-Ganz catheter, always take it right before the dip. Now, when you put air into the balloon, you get a wedge. I like to say that the normal wedge is 4 to 12. Some books say 6 to 12. Some books say 6 to 14. I like 4 to 12. So when you take a wedge, or when you put air into the balloon to get a wedge, you will notice that the waveform will change, and you'll get a bunch of little humps. You'll get a wave, a C wave, and a V wave. An A, C, V. An A, C, and a V. And the A wave is really indicative of atrial contraction, and the C wave is indicative of mitral valve closing. I really don't pay attention to the C waves. And the V waves is atrial filling. So that the A wave and the V wave are the most important waves to look at when you're looking at a wedge. And it's very important to correlate the wedge recording with the EKG above it, because that's how you'll be able to find the A wave. Because whenever you do a wedge, you can't get the number off the machine. It is never accurate. The machine always averages all the humps, and it will not be accurate. What you have to do is you have to find the A wave and take the mean of the A wave. That is the only way that you can get a wedge. You got to take the A, find where the A wave is, and take the mean of the A wave, and that's how you will get a wedge. So that when I put air into the balloon, I will get an A wave, a C wave, and a V wave. The A wave is atrial contraction, and you find it after the QRS. So the A wave is after the QRS, usually there's a C in that, and then you get a T wave. You get an A, C, and a T. I'm sorry, a V. You get an A, C, and a V. So we have an A wave, a C wave, and a V wave. Now, I said the A wave is the most important wave, because you look at the A wave, you take the mean of the A wave, and that's how you get a wedge. And I said that the A wave is indicative of atrial contraction, but you find it after the QRS. Now, most people will say, well, if it's an A wave is atrial contraction, you really should find it under the P wave, because the P wave is atrial contraction. But the tubing on a Swan-Ganz catheter is so long, that's why the A wave occurs after the QRS. Even though the A wave is atrial contraction and a P wave is atrial contraction, you would think it should be right down here. But the tubing is so long, because you've got tubing that comes from the patient, and then from the patient goes to the pole, then it's on the transducer, then it goes down over here, then it's on the floor, then it goes up to the monitor, and then it plugs in. It's long. And by the time it takes the mechanical waves to be converted into electrical waves, the amount of time that takes causes the A wave, which is atrial contraction, to be found after the QRS. So the A wave is found after the QRS. And the V wave, which is atrial filling, is found after the T wave. So very important in doing a wedge, you got to find the A wave and take the mean of the A wave, and that's how you get a wedge. You cannot look at the numbers on a machine. It will never give you an accurate reading. Never. So we put air into the balloon, and we get a wedge. This is a wedge. How do I know? I don't know. Pick a hump. Let's pick this one over here. Pick a hump, bring it up. It's right after the QRS. So this is a A wave. C wave's inside. This hump is a V wave. How do I know? After the T wave. This is A wave, right after the QRS, and this is a V wave. AV, AV, AV. And in order to get a wedge, you get the A wave and take the mean of the A wave. And usually you get the mean of the A wave right before the dip. Put air into the balloon. You get a wedge pressure. A lot of nurses, in looking at this bottom one, would go to the phone, call the doctor and say, the Swan won't wedge. Swan won't wedge. Hasn't wedged since you put it in. But this is a wedge form. People are like, no, it's a pulmonary artery pressure. No, it's not. If it's a pulmonary artery pressure, this configuration would be right under the QRS, and it's not. What is this? It's a wedge. How do I know? Pick a hump. I bring it all the way up. It's right after the QRS, so this is a wave. This hump is right after the T wave, so this is a V wave. AV, 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 AV. And in order to get an accurate wedge, you've got to find the A wave and take the mean of the A wave. It's 27 over here, 14 over here, and the mean of that is like 25 and a half. So the wedge is 25. That makes sense? Okay. So pulmonary artery wedge pressure. The wedge will be elevated whenever you have a heart problem. The wedge looks at the heart. Whether you have mitral valve problems, whether you have cardiac tamponade, it's going to be elevated. It'll be elevated with constrictive pericarditis. It will be elevated with left ventricular failure and volume overload. Oop. So your wedge will be elevated in these conditions. Your wedge will be low if you're intravascularly depleted or if you're in shock. Okay, now moving on. The PAD, the pulmonary artery diastolic number, the normal should be like 6 to 12, correlates with the left ventricular end diastolic pressure, usually. And the PAD correlates with the wedge pressure. Because a lot of times physicians will say, don't wedge a swan, just look at the PAD, because usually it is reflective of the left ventricular end diastolic pressure, except in certain conditions. And the wedge correlates with the left ventricular end diastolic pressure. So the PAD, the wedge, and the left ventricular end diastolic pressure should pretty much all be the same. The only thing you got to remember is the wedge is always a little bit lower than the PAD. Matter of fact, the wedge always has to be lower than the PAD. Matter of fact, the wedge could never be higher than the PAD. Yet I bet you $1 trillion, if you got somebody with a swan and people are wedging it, I bet $1 trillion the wedge is always higher than the PAD. But it can't. Physiologically, it's impossible. They're probably getting the number off the machine when they do the wedge, as opposed to finding the A wave and taking the mean of the A wave. So your wedge can never be higher than your PAD. Because you see, the wedge should not be greater than the PAD because blood flows from an area of higher pressure to lower pressure in order to move forward. So your wedge always has to be lower than your PAD. So can I be 32 over 20 with a wedge of 22? No. Could I be 28 over 16 with a wedge of 20? No. Your wedge can never be higher than your PAD. Could I be 24 over 10 with a wedge of 14? No. Your wedge can never be higher than your PAD. If it is, it means something. Usually means your catheter is in the wrong place. That's what it usually means. Or maybe the patient's on PEEP greater than 10. The discrepancy is caused by either over-wedging the catheter, but you would know that because you get a line all the way on the top, or some physiological condition. Maybe the catheter is in the wrong zone, or maybe your patient's on a PEEP greater than 10. The catheter must be in zone 3. If it's in zone 1, which is the top, you see the alveoli clamp down on the capillary beds, and there's not an opening to look at the left side of the heart. When you have the catheter in zone 2, whenever you take a deep breath in and your alveoli open up, it clamps down on the capillary bed, and there's not an opening to look at the left side of the heart. So you see the catheter has to be in zone 3 in order to get an accurate reading. And how do you know it's in zone 3? Well, usually somebody got to take an x-ray and somebody got to read it. That's usually how you do it. So a lot of times you say the attendings or the interns or residents, you know, did you take an x-ray on Mr. So-and-so? Yeah, is the catheter in place? Is it in zone 3? They're like, what? Is the catheter in zone 3? What are you talking about? How do you know the catheter is in the wrong zone? Well, if you don't have anyone that knows how to read an x-ray, there are ways that you could tell it's in the wrong zone. Dampened wedge tracing. No matter how much you pump this up, pull this, squeeze this, no matter what you do, you have a very dampened tracing. In other words, you can't find a good hump. You can't find a good A wave or a V wave. It's very dampened, no matter pulling this, maybe pumping this up, whatever. You get a very dampened tracing. That could mean it's in the wrong zone. Or your wedge is higher than your PAD. Whenever your wedge is higher than your PAD, catheter's in the wrong place. Can't find an A wave or a V wave because the pressure is very dampened. Or sometimes you got lots of marked respiratory variations. In other words, you're looking at the waveform. It's all over the place. A lot of people call that catheter a whip or catheter fling. It could just be the catheter's in the wrong place. Another thing, when someone is on PEEP greater than 10, the wedge will not be accurate. Whenever somebody is on a PEEP greater than 10, not 10, but greater than 10, your wedge is not going to be accurate. And you have to do a mathematical equation in order to make it accurate. Now, for the exam, you just have to know that when you are on a PEEP greater than 10, your wedge will not be accurate. That's what you have to know for the test. Anyone on a PEEP greater than 10 has to be greater than 10. Not 10, but greater than 10. Your wedge is not going to be accurate. In clinical practice, you should know the equation on what to do. The PEEP is measured in centimeters of water, and the wedge is measured in millimeters of mercury. So what you have to do is you have to take the PEEP, which is centimeters of water, and change it into millimeters of mercury. How you do it is this. You take the PEEP, divide it by 1.36, and then divide it again by 2. So the numbers you got to remember is you take the PEEP, divide it by 1.36, and then divide it again by 2. So 1.36 and 2. So for example, I have someone on a PEEP of 15. I did a wedge and I got 18. That's not an accurate wedge. Why? He's on a PEEP greater than 10. So what I have to do is I have to take the PEEP, which is 15, divide it by 1.36. I get 11. Divide that again by 2, and I get 5.5. And that number you get, you subtract it from your recorded wedge in order to get your real wedge. So my recorded wedge was 18. But now I subtract 5.5 from it, and my real wedge is 12.5. Big difference. 18, you think he's going into failure. 12.5, he can go home now. On PEEP. Yeah, let's just do a few more. I have someone on a PEEP of 20. I have someone on a PEEP of 20. You got a recorded wedge of 22. What's the real wedge? I take the 20. I divide it by 1.36, come out with 14. Divide that number by 2, and I come out with 7. I take that 7, subtract it from my recorded wedge in order to get my true wedge. So my recorded wedge is 22, but the real wedge is 15. Big difference. I have someone on a PEEP of 14. You get a wedge of 12. That's not accurate because he's on a PEEP greater than 10. I take that 14 of PEEP. I divide it by 1.36, come out with 10. Divide that by 2, come out with 5. I subtract that 5 from my recorded wedge, which is 12, in order to get my real wedge, which is 7. I have someone on PEEP of 18. I take the 18, I divide it by 1.36, and I get 13. I divide that by 2, and I come out with 6.5. So now, my recorded wedge is 16. I subtract the 6.5 from that, thus my true wedge is 9.5. I have someone on a PEEP of 16, greater than 10. So I take the 16, divide it by 1.36, come out with 11. Divide that by 2, I come out with 5.5. I subtract that 5.5 from my recorded wedge in order to get my real wedge. So you should make like a little chart hanging on the pole or something, that, 11 divided by 1.36, blah, 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 12, PEEP of 12 divided by 1. You should do that. Why don't you make a little laminated cards? Hey, why don't you sell it? PEEP cards or something, I don't know. Okay, that's easy. And remember, your wedge can never be greater than your PAD. Good. Let's say a few words about heart murmurs. Tell you, it makes you want to go into work, doesn't it? No, eh? We'll get you there. We'll get you there. Here we go. Murmurs. Now, there are two common causes of a murmur, right? Two common causes of a murmur, right? The first cause of a murmur would be the forward flow of blood. The forward flow of blood through stiff stenotic open valves. So the first cause of a murmur would be the forward flow of blood through stiff stenotic open valves. Whenever you have heart valves that are all like stiff and stenotic and they don't open good, you're going to get a murmur. So the first cause of a murmur would be the forward flow of blood through stiff stenotic open valves. That whenever you see the word stenosis, that tells you that that murmur was made when that heart valve is open. You read that someone has mitral stenosis, that tells you that that murmur was made when that mitral valve is open. Pulmonic stenosis, that tells you that that murmur was made when that pulmonic valve is open. So whenever you see the word stenosis, that tells you that that murmur was made when that heart valve was open. I say stenosis, you say open. I say ADH, you say water. Learning has occurred. Another cause of a murmur would be the backward flow of blood. The backward flow of blood through valves that are incompetently closed. Whenever you have heart valves that just don't close good, the blood will go backwards through it and give you a murmur. And that's known as insufficiency. Insufficiency is a backward flow of blood through incompetently closed heart valves. So whenever you see the word close, you say insufficiency. I say open, you say stenosis. Well, really, when I say stenosis, you say open. Hello. No, I'm being a little dyslexic. So whenever you read that someone has mitral insufficiency, that tells you that that murmur was made when that heart valve was supposed to be closed. Aortic insufficiency, that's a murmur that's made whenever that aortic valve is supposed to be closed. I say insufficiency, you say? I say stenosis, you say? Good. Very important you be in the right place in order to hear a murmur. If you're not in the right place, you're not going to hear it. Like I come out of a patient's room and I say to my friend, this guy has aortic insufficiency, you can hear from the cafeteria. She's like, oh my God, let me hear. So she goes running in there and she got a stethoscope all over his chest. She's all over him. She's all over him. And she's looking at me going, you know, she can't hear it. So I go in there and I'm like, so now she's like, you know, she hears it now, right? We'll be doing murmurs in a minute, but aortic insufficiency is lup-dub, 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 lup-dub. Hey, not in the place, not going to hear it. Got to be in the right place. And you don't have to count intercostal or whatever. It's just in the general right area. So the four areas are aortic, pulmonic, mitral, and tricuspid. Aortic area is on the right side. Like in this area here, second intercostal space, right side. That's a little confusing because your aortic valve's on the left side of your heart, yet you hear it on the right side of your chest. It's because you hear the murmur where the heart valve sends the blood. So even though my aortic valve's on the left side of my heart, I hear it on the right side of my chest. Aortic murmurs in this area. Pulmonic murmurs are heard on the left side, and that's confusing because your pulmonic valve is on the right side of the heart, yet you hear it on the left side of the chest because you hear the murmur where the heart valve sends the blood. So you have aortic area, you have pulmonic area. Mitral area is a fifth intercostal space, mid-clavicular line. So it's right around here, the apex, mitral area. And then when you move over towards the sternum, that's the tricuspid area. So you have aortic, pulmonic, mitral, tricuspid. Aortic, pulmonic, mitral, tricuspid. And you've got to be in that general area in order to hear things. And what are you going to be hearing? Well, there are systolic murmurs and diastolic murmurs. When people have a diastolic murmur, that's a murmur that occurs during diastole, you're going to hear lub-dub murmur, lub-dub murmur, lub-dub murmur. And when someone has a systolic murmur, you're going to hear lub murmur dub, lub murmur dub. Let me go back to diastolic murmur. That's a murmur that occurs during diastole. That's a murmur that occurs when your left ventricle is filling. So that a diastolic murmur is lub-dub murmur. Because lub, and S1, is the closure of the mitral tricuspid valves. Whenever your mitral tricuspid valve closes, you get a S1. Then after my mitral tricuspid valve closes, then I'm going to be in systole, and I'll squeeze the blood out. Then after all the blood's out of the heart, the aortic pulmonic valve closes, and I get an S2. And then after that, my heart's going to fill. I'm in diastole, and that's when you hear a diastolic murmur. So a diastolic murmur is lub-dub murmur, lub-dub murmur, lub-dub murmur, lub-dub murmur. A systolic murmur, on the other hand, occurs during systole, when your ventricles are contracting. So that a systolic murmur is lub, murmur, dub. Because an S1 is the closure of the mitral tricuspid valves. Whenever my mitral and tricuspid valve close, I get an S1. Then I'm going to squeeze the blood out of the heart, that's systole, that's when I hear the murmur. And then the aortic pulmonic valve closes, and I get an S2. So it's an S1, murmur, S2. Lub, murmur, dub, lub, murmur, dub, as opposed to lub, dub, murmur, lub, dub, murmur. I'll say the murmur, you tell me whether I'm systolic or diastolic. Lub, dub, murmur, lub, dub, murmur, lub, dub, murmur. Very good. Lub, murmur, dub, lub, murmur, dub, lub, murmur, dub. Systolic. There'll be no living with you when you go back to work. That's it. Just march into someone's room. Let's say you're reading somebody's chart that they have the murmur of mitral stenosis. You say to yourself, mitral stenosis is a murmur that is made whenever the mitral valve is open. Because I say stenosis, you say? I say insufficiency, you say? Good. So you're reading somebody's chart that they have the murmur of mitral stenosis. So that tells you that that murmur is made whenever the mitral valve is open. Then you say to yourself, when's the mitral valve open? And then you say the mitral valve is open when the blood's plumping from the left atrium down into the left ventricle. So the mitral valve is open during diastole. Therefore, mitral stenosis must be a diastolic murmur. I'm going to go into the room and I'm going to sing lub, dub, murmur, lub, dub, murmur, lub, dub, murmur, lub, dub, murmur. You're reading somebody's chart that they have the murmur of aortic insufficiency. You say to yourself, aortic insufficiency is a murmur that's made whenever the aortic valve is supposed to be closed. When's the aortic valve supposed to be closed? During? The aortic valve is closed during? Sounds like diastole. The aortic valve is closed during diastole. Therefore, it's a diastolic murmur. Going to walk into the room, what are you going to sing? Lub, dub, murmur, lub, dub, murmur, lub, dub, murmur. Here, we'll do more. You're reading in somebody's chart that they have the murmur mitral stenosis. You say to yourself, mitral stenosis is a murmur that is made whenever the mitral valve is open. When's the mitral valve open? During diastole. Therefore, it's a diastolic murmur. Going to walk into the room, and what are you going to sing? Lub, dub, murmur, lub, dub, murmur, lub, dub, murmur. You're going to put your stethoscope over here, in the mitral area, and you're going to hear lub, dub, murmur. Now, the murmur of mitral stenosis is rumbling. You don't have to know for the exam, crescendo, decrescendo. You don't have to know that. Not at all. You know, late systolic, early systolic. You're lucky to hear the stupid thing. You just got to know it's rumbling. Right? So what it sounds like when people have mitral stenosis, it sounds like this. Lup da brr, lup da brr, lup da brr, lup da brr. You do it. Hit it. Lup da brr, lup da brr, lup da brr. Nurses always think it's water in the ventilator tubing. You know when someone on a ventilator and get that water in that tubing, they always think there's water in there. They're like, you know? And they don't know where they're dumping it. They're just dumping it like this. You know, I've been doing this all day. I can't seem to get that noise out. I'm like, you keep disconnecting it from the ventilator. It'll go away. So mitral stenosis is lup da brr, lup da brr, lup da brr, lup da brr. Very good. And some of the causes of mitral stenosis, that rumbling noise at the apex, would be calcification of leaflets. You're reading somebody's chart. That they got the murmur of aortic insufficiency. You say to yourself, aortic insufficiency is a murmur that is made whenever the aortic valve is supposed to be closed. When's the aortic valve supposed to be closed? Diastole. So you're going to go into the room, and what are you going to sing? Lub, dub, murmur, lub, dub, murmur, lub, dub, murmur. That's it. Just walk around the unit doing that. They're like, Helen, I think she needs a mental health day. Keep them guessing. Really, act like you have a screw loose. No, really. They leave you alone. They just leave you alone. They just leave you alone. Really, you'd be better off. Act like you have a screw loose. And then I always like to cause a little commotion for administration, you know? I'm sure there are some good ones, without a doubt. I just never worked with any of them. But anyway, I'm sure there's some good ones somewhere. Okay, so here we go. So aortic insufficiency, you're going to hear it over here in the aortic area. Lub-dub murmur, lub-dub murmur. And the murmur of aortic insufficiency is blowing, right? It's blowing. You don't have to know high pitch, low pitch, crescendo, decrescendo. You don't have to know that. It's a bunch of blowing. That's what you hear. So it's lub-dub, 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 lub-dub. You do it. Hit it. Lub-dub, 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 lub-dub. So that's aortic insufficiency. So that's good. We'll learn two murmurs. Mitral stenosis, aortic insufficiency. Mitral stenosis, lub-dub, lub-dub, lub-dub. Aortic insufficiency, lub-dub, lub-dub, lub-dub. Good. And some of the causes of aortic insufficiency would be systemic hypertension and rheumatic heart disease. Matter of fact, rheumatic heart disease is probably the most common cause of all the murmurs. All right. You're reading somebody's chart that they have the murmur of aortic stenosis. You say to yourself, aortic stenosis is a murmur that's made whenever the aortic valve is open, right? When's your aortic valve open? During systole. Therefore, it's a systolic murmur. You're going to go into the room, what are you going to sing? Lub, murmur, dub. Lub, murmur, dub, lub, murmur, dub. But aortic stenosis, holosystolic murmur. It's a holosystolic murmur, meaning you hear it all throughout systole, which means it's so loud you don't even hear the lub dub. You just hear the murmur. That's all. And the murmur is described as rough, gruff, and harsh. Really, if you read the medical book, they say it sounds like a washing machine. Personally, if your washing machine is making the noise I'm going to be making soon, I'd buy a new washing machine. But anyway, and it radiates all over the place. No, it does that. You do it. Hit it. No, it sounds just like that. I'm taking care of a patient, and he had it really loud. You could even hear it without the stethoscope. So I told him, I said, you want my stethoscope? Yeah, I said, you have a murmur, I want you to hear it. He says, I hear it all the time. I said, oh, so you hear it? He says, I hear it all the time. In my head, I hear it all the time. I said, so when you lie down and go to sleep, you hear that? He's like, all the time. I'm like, don't you want to kill yourself? I mean, I would want to kill myself. I really would. That would just make me just want to jump out of a plate glass window, you know? But then he said, you know, he says, you get used to it. It's like a bad house smell. I'm like, all right. I said to him, I said, you know, you're going to live a long time. You have a really good attitude. I guess when you lie down and you don't hear it, you get nervous. But anyway. So aortic stenosis, right? It's very harsh, gruff, and rough. It radiates to the neck and the carotid, right? Sounds just like that. Little old ladies always have aortic stenosis. Really, because whenever you're old and you're a lady, you're going to get aortic stenosis because the calcium comes out of your bones and hangs around your valves. So little old ladies always have aortic stenosis, and they always have atrial fib. I dare you to find a little old lady who is not in AFib. They all have AFib. And whenever you have AFib, your heart rate's very irregular, right? Very, very irregular. So when you have AFib with this harsh, rough, and gruff aortic stenosis, it sounds like this. Sounds just like that. Nurses always put scattered rhonchi. Oh, it's got scattered rhonchi. You know, and they tell you, I've been suctioning all day long. I can't seem to get that out. I'm like, you keep disconnecting the ventilator and suction her. It'll go away. That noise will go away. Don't worry about it. And you're reading somebody's chart that they have the murmur of mitral insufficiency. You say to yourself, mitral insufficiency is a murmur that is made whenever the mitral valve is supposed to be closed. Now, when's that mitral valve supposed to be closed? During systole. Therefore, mitral insufficiency is a systolic murmur. going to go into the patient's room, and what am I going to sing? Love murmur dub, love murmur dub, love murmur dub. But it's another holosystolic murmur, meaning you hear it all throughout systole, meaning it's so loud you're just going to be hearing the love. You don't even hear the love dub, you just hear the murmur, which is blowing. Mitral insufficiency is just pure blowing, and it radiates all over the place. That's it. You do it. Hit it. Keep going till the first one passes out. I'll give you $100. If you ever have kids, it's a good way to get them to go to bed. Because sometimes kids don't want to go to bed, especially if you take in foster kids. They come from families that don't, sometimes don't have structure or whatever. But I'm a real stickler about bedtime. A big stickler. You're to be in bed by 8 o'clock. Keep the lights on. No problem. No TV. It's only crap on after 8, except the X Factor. But anyway, you have to be in your bed, all right? You can keep the light on, you can watch TV, and play with your truck, whatever you want, just got to be in bed, okay? Because after 8 o'clock, we have big snakes that live under the bed, and they crawl around the floor, and they look for kids' legs to eat. So you really have to get in the bed, right? I'm like, Laura, you're scaring them. I'm like, they know I'm only fooling, right? No. And the reason I got to be there, because when you have a million kids, you really need time for yourself, okay? I don't want to hear you, I don't want to look at you, I love you, but I don't want to look at you, so stay in your bed, okay? But some children, like Justin used to give me such a hard time. He used to tell me his parents let him stay up to 2 o'clock in the morning, sometimes he'd be up to 4, he didn't have to, the kid's 7 years old. Sometimes he didn't have to go to sleep at all. I'm like, well, this house, we have rules, and you got to follow them, okay? But he'd give me a hard time. I'm like, listen, I'm not going to get into an argument. I'll make you a deal. You take 50 big, deep breaths, and you can stay up to any time you want, all right? So I get all the boys in the bed, I lower the lights, I put on nice music. I'm like, okay, let's count. 1, take a deep breath. Let it out. Do it again. And what happens is they go into such a state of alkalosis, they're nothing but tingly. They're all tingly. Oh, the 2-year-old, they're all tingly. So anyway, if your kids aren't listening to you, just hyperventilate them. They get very alkalotic, they get tingly, and then they go to sleep. That's it. So mitral insufficiency, right? Bunch of blowing. Good. And some of the cause of mitral insufficiency would be a myocardial infarction, inferior wall, and rheumatic heart disease. So just to go through the murmurs, we have mitral stenosis, lup-da-brr, lup-da-brr, lup-da-brr. Mitral insufficiency, I'm sorry, I'm doing a little. Mitral stenosis, lup-da-brr, lup-da-brr, lup-da-brr. Mitral insufficiency, aortic insufficiency, lup-da, lup-da, lup-da. Aortic stenosis. Good. But you got to be in the right place. That's it. And again, this is just for you to look at with that wedge pressure, just to refresh your memory. An A wave is found after the QRS. To get an accurate wedge, you got to measure your A wave. And then in looking at this, a lot of people think it's a pulmonary artery pressure. It is not. It is a wedge pressure, but we have giant V waves. And the reason why we have giant V waves is a V wave is atrial filling. And when you have mitral insufficiency, you have a condition where the mitral valve don't close good. And blood is backing up from the incomplete blood is backing up from the left ventricle through the incomplete closed mitral valve into the left atrium. And if blood is flooding into the left atrium, it's filling the left atrium. So the tip of the catheter sees the blood coming up through the incomplete closed mitral valve into the left atrium. And the tip of the catheter sees that. Whoa, whoa. And that's why you got giant V waves. That's why you can't press the button on the machine to get a wedge, because that machine's going to average all the heights of all the humps, and you're not going to get an accurate wedge. You got to find the A wave and take a mean of the A wave. And we end there. So 1:45, take a break. If you come back, we're going to do cardiovascular part 2. See you in about 15 minutes. Okay. Back to work, cardiovascular. Cardiovascular part 2. Remember, there's only 20%, and only going to be 30 little itty bitty baby questions. So cardiovascular, very easy. Okay, here we go, cardiovascular. We're going to say just a few words about cardiac cath. That's something new on the exam now. Really, they only focus on your nursing interventions after the procedure. But let me just give you a little overview. Cardiac catheterization is done to confirm and define the extent of coronary artery disease, to evaluate cardiac function in heart disease, and to perform catheter-based interventional procedures in order to treat coronary artery disease. Now, there's right-sided catheterization, and then there's left-sided catheterization. The right-sided catheterization would measure right atrial and ventricular pressures. It also can measure the pulmonary artery pressure, the oxygen content on the right side of the heart. You can detect any kind of shunt, whether it be right to left, left to right shunt. It also determines the cardiac output, evaluates the valves on the right side of the heart, which are tricuspid and the pulmonic valves, and also perform physiological studies. Left-sided catheterization is done in order to evaluate the coronary arteries, determine the location of any coronary lesions in those arteries, measure left-sided ventricular pressures, evaluate the valves on the left side of the heart, which is mitral and aortic, evaluate left ventricular function, and perform interventional procedures on the coronary arteries. Cardiac catheterization. Percutaneous coronary intervention is the treatment of coronary artery disease via a catheter-based procedure. PCI is performed via left heart catheterization and would include PTCA, stents, drug-eluting stents, and directional rotational translumal extraction atherectomy. Now, nurses should be aware of the importance of continued aspirin and Plavix therapy in patients with drug-eluting stents or implants. Stress the importance of taking these drugs when doing patient teaching. Patients must consult with cardiologists before discontinuing any aspirin or Plavix, even for diagnostic or surgical procedures. This is what we got to know. Nursing care post-op. Manual pressure, 20 to 30 minutes until bleeding is controlled. Vital signs and distal pulse checks. Observation of access site for bleeding or hematoma formation. Observation of extremity below the access site for color, temp, and movement. Every 15 minutes, vital signs are done for the first hour, and then every 30 minutes for the second hour, and then usually hourly. And bed rest with the affected leg, and this will vary depending on where you work, but according to AACN, 2 to 4 hours. And that's what we got to know. And you already know this, common sense. When you talk about cardiac catheterization, there are some complications: death, big complication, CVA, myocardial infarction, and renal dysfunction due to an emboli or maybe even the contrast. The most common complications are local vascular problems at the insertion site, and they are hematoma, retroperitoneal bleeding, thrombosis, and distal embolization. Measures to prevent contrast-induced nephropathy include a low dose of contrast as possible, lots of IV fluids, normal saline, lots of that, and you can even give Mucomist, which has an antioxidant and vasodilatory effect, the day before and the day of the procedure. And nephrotoxic drugs such as antibiotics, some of the aminoglycosides, cyclosporin, non-steroid anti-inflammatory drugs, and metformin must be withheld 24 hours prior to the procedure. When you talk about acute coronary syndrome with ACS, there is an urgency for treatment to preserve myocardial function. After 20 minutes of oxygen deprivation, irreversible cellular injury can begin. Acute coronary syndrome includes unstable angina, non-STEMI, ST elevation MI, and STEMI, ST elevation MI. Patients presenting with STEMI are candidates for reperfusion therapy. Now what we're going to do is we're going to move on and look at a 12-lead EKG. Sometimes they put 2, sometimes they put 3 of them on there. I'm thinking since they reduce the percentage, it's going to be a little less, maybe only C1, but you want to get it correct. So let's read a 12 lead EKG. Leads 1 and AVL will look at your lateral wall, because when you're monitoring someone in lead 1 or AVL, you know that in lead 1, your left arm, and in AVL, your left arm is positive. So lead 1 records the electrical activity between the right arm and the left arm is positive. And AVL records the electrical activity between the imaginary point in the heart and the left arm. So you see that in lead 1 and in AVL, the left arm is positive. And it's the positive sticky that looks at your heart. So if I'm in lead 1 or if I'm in AVL and my left arm is positive, I am looking at the lateral wall of the heart. So lead 1 and AVL look at the lateral wall of the heart. Now, whenever the wave of depolarization or whenever the electricity is going through the heart towards a positive sticky, your complex is up. That's why whenever you look at lead 1 or AVL, complex should be going up. If you're looking at lead 1 and AVL and you notice that your complex goes up and then mostly down, that means something. Now, a lot of nurses will tell you it's electrode placement. Because they'll say, hey, how come that goes down? They're like, oh, it's electrode placement. It's electrode placement. You know, or sometimes they say, oh, he's on his side. Or sometimes they say, oh, he had a heart attack. So these are your friends lying to you. There's a reason why you go up and then mostly down in lead 1 or AVL. In lead 1 or AVL, the left arm is positive. Electricity. So you're going towards the positive sticky. That's why it goes up a little bit. Hey, Joe, check out the right ventricle. Wow, it's about 5 times the normal size, and how do you think it got that big? I don't know. I think the guy has COPD for the last 50 years, and the right ventricle hypertrophy. It's gigantic. We better go over there. So now the electricity is going away from the left arm. When you're going away from the positive sticky, you get a downward complex. And if I'm going away from the left arm, I'm going over to the right. So if I have a complex in 1 in AVL that goes up and then mostly down, that's known as a right axis deviation. And you should be dramatic about this at work, because no one ever knows this axis deviation, no? So like when a cardiologist walks in, you can pick up a 12 lead and say, oh, Donna, did you see Mrs. Jones's 12 lead? She's developed a right axis deviation. Wow, where did we go to medical school? Well, I didn't have to. Axis deviation just tells you the direction of electricity. And then lead 2, 3 and AVF, look at the inferior wall. Right? Lead 2, 3, and AVF. Lead 2, lead 3, and AVF look at the inferior wall. Because in lead 2, you're recording the electroactivity between the right arm and the left leg. In lead 3, you're recording the electroactivity between the left arm and the left leg. And in AVF, you're recording the electroactivity between an imaginary point in the heart and the left leg. So you see that in lead 2, lead 3, and AVF, the left leg is positive. And it's your positive sticky that looks at the heart. So if I'm in lead 2, lead 3, and AVF, I am looking at the inferior wall. Whenever the wave of depolarization goes through the heart towards the positive sticky, how am I supposed to be? Up. That's why whenever you look at 2, 3, and AVF, you're looking at the inferior wall, and the complex should be going up. If you're looking at someone's 2, 3, and AVF, and you see that in lead 2, 3, and AVF, your complex is going up and then mostly down, it means something. It doesn't mean electrode placement, doesn't mean it's on the side, doesn't mean it had a heart attack. Here's what it means. 2, 3, AVF, left leg positive, electricity. So I'm going towards the positive sticky, that's why it goes up a little bit. Hey, Joe, check out the left ventricle. Wow, it's about 5 times the normal size, and how do you think it got that big? I don't know. I think he's been walking around with hypertension for the last 50 years, and the left ventricle hypertrophy. It's gigantic. It's under that armpit, and we better go there. Because that's where your left ventricle goes whenever you have left ventricular hypertrophy. It goes under your armpit. It doesn't hang out like an external package, but it shifts over that way. Because you ever do an apical and you don't hear anything? Like you ever be listening to somebody's heart and you don't hear anything? And you know he has a heart, his eyes are open, you're having a conversation, but you don't hear anything. You're like, where the heck's this guy's heart? Then you figure maybe it's on the other side, but it's not. Then you figure it's your stethoscope. Go back on the chest, you still don't hear anything. Now you don't want to move it around anymore because he's looking at you as if to say, jerk, what's up? You can't hear my heart? So you just hang out. You don't hear nothing, you hang out, you make like you're counting. You're like this. You don't hear anything. Heart rate says 78, it's heart rate 78. That's it. Eyes are open, I give him 24 respirations. If his eyes are closed, I give him 14. Okay, enough, give him that. So anyway, if I'm in lead 2, 3, and AVF, and my complex goes up and then mostly down, here's what's happening. And now I'm going towards the left ventricle. I'm going away from the positive sticky, that's why it goes down. And if I'm going away from the positive sticky, I'm going over to the left. So if I have somebody in leads 2, 3, and AVF, and their complex goes up and then mostly down, that's known as a left axis deviation, right? And be dramatic. Oh, did you have a lot of fun at work? So axis deviation just tells you the direction of electricity. Really, the only purpose it really serves is to read hemiblocks, right? It serves the purpose to read hemiblocks. I mean, this part's not on the test, but I'll tell you this anyway. In order to read a hemiblock, you have to know axis deviation. So let me just tell you this. The most common hemiblock is a left anterior hemiblock. Right? You probably see LAH when you look at 12 leads and stuff. And what a left anterior hemiblock is if this is the heart here, primitive, this is your left bundle, which has two pathways, or what do I want to say? What's the word I'm looking for? Pathways? It'll come to me. And then this is your left bundle. Okay, so this is your right bundle, and there's your left bundle. Your left bundle has two branches. Okay, if someone has a left anterior hemiblock, they have a block on one of their fascicles. One of their fascicles is blocked, so I'll just erase this, all right? So in order to read a left anterior hemiblock, if you read most books, it has about 100 criteria, but I only know 2 of them, and it always works. The first criteria is you need a left axis deviation, which is looking at 2, 3, and AVF, and then looking at lead 2, and looking at lead 3, and AVF, I see this. So this is a left axis deviation. And the second criteria would be little baby Q waves in one and in AVL. Little baby Q waves in one in AVL. So little baby Q waves, negative deflection, little baby Q waves in one and in AVL. Okay, and that is a left anterior hemiblock. So I go float into CCU and they have everybody on lead 2. Why, I have no idea. It's the most stupidest lead to keep anyone in. You're better off shutting off the monitor. Shut the monitor off and say to a significant other, when you see his eyeballs roll back, give me a call, all right? But anyway, they have them in lead 2 in CCU because the nurse manager doesn't think anyone could handle 2 leads at one time because they have a 5-sticky system, and having a 5-sticky system, you could read any of the limb leads and V1, but she doesn't think we could look at 2 leads at one time. So anyway, they promote people like this in hospitals. I don't know if you noticed. Let's say you come to my hospital, you're looking for a job, all right? Let's say you have no personality whatsoever. You have no social skills. You don't have any friends. You're untouched by human hands, man or woman. Your face is all contorted in misery and grief. Boom! Right to the top! Right to the top! You're hired. You're miserable? You have no friends? You're hired. It's like, hello. Oh, they really need to get likable people in nursing administration, especially when you're dealing with women, because if we like you, we will die for you, really. If I like you, I will die. I will give you my only kidney. That's how women work, but they get such miserable people contaminating a whole unit. I don't get it. I just don't get it. Anyway, so I'm working at CCU and have everyone on lead 2. This is lead 2. And I noticed that on the monitor, my patient's doing this. So in looking at this, I said, oh, he has a left axis deviation. Then I happened to be looking more, and I noticed he had a prolonged PR interval. So I'm like, oh. So then I said, let me get the 12 lead. So I look at the 12 lead, and I notice that in V1, right, V1, he's doing this. So I said, oh, he has a right bundle branch block. So he has a right bundle branch block. Okay. He's got a left anterior hemiblock. Okay, so right now he's hanging by a thread. And he has a first-degree AV block. So really, he's got first-degree AV block. He's got a left anterior hemiblock. And he's got a right bundle branch block. So he has a trifascicular block, and he doesn't have a pacemaker in. I'm like, hello, why do you have him here? What, so he could die and we can put him in a morgue? I don't understand. Why is he here? So I wound up calling up the doctor. I got in a little bit of trouble because I didn't go up the chain of command. I am to go to the supervisor first before calling any physician at home. So I got in trouble, but that's all right. Then, the doctor did come in and put a pacer in, so that was a good thing. But you get in trouble, you get written up. Why don't I get written up for any good things I do? Can we have 2 files here? Can I have 1 file cabinet when I did something wrong? And how about a file cabinet when I do something right? All right? Hello? I don't get it. I don't understand. Yeah, so I said to him, I said, what are we doing here? The guy is in a trifascicular block, and he's lying in bed. He doesn't have a pacemaker, and you write an order for morphine if he has chest pain. Well, why don't we just give him potassium chloride IV push? I'm thinking that'd be like, hello. All right, so anyway, this is your limb leads, and this is what it's supposed to look like. Now let me show you your anterior septal wall leads, V1, V2, V3, V4, V5, V6. Now you'll notice as you progress from V1 through V6, your R wave should be getting a little taller. That R wave is the upward deflection, and it's very good to have an R wave, because to have an R wave in V1, V2, V3, V4, it means that you have a very healthy and happy anterior septal wall. So it's good to have an R wave in V1, V2, V3, V4, V5, V6. So let me just show you what you're supposed to look like in V1 through V6, all right? Initially, the impulse always goes down the left bundle first. I always thought impulses went down both bundles at the same time, but it doesn't. It goes down the left bundle first. It goes down the left bundle, goes across the ventricular septum, goes across the anterior wall in this direction towards V1, V2, V3, maybe V4, and that's why you have an upright complex. As the impulses are going across the ventricular septum and the anterior wall in this direction, it will initially go down in V5 and V6. And you will call that a septal Q. It's only the size of a baby box. It's not big. But you get the septal Q because the impulses are going away from the positive sticky. And that's a good thing. That's a good thing. And so the impulse will now jump on the right bundle, go through the Purkinje fibers, and then depolarize the right ventricle in this direction, away from V1, V2, V3, V4. So now my complex should be going down, and it continues to go in this direction towards V5 and V6, and that's why it will now be going up. So whenever you look at V1, V2, V3, V4, I don't look at V4, I don't pay attention to V4, I don't know where to put V4, really, to tell you the truth. I mean, I know V1, V2, V3. I'm not sure where to put V4. Like, if you have breasts that are all droopy and everything, I'll just stick it over here. But if you've got breasts that stick up a little bit, I'm not too sure where I put V4. Do I lift your breasts up, put over here, flip your breasts down? I don't know. So I don't do V4. People say, how are you going to read a 12 lead? If you can't read a 12 lead by looking at 11 other leads, V4 is not going to make or break your interpretation. I don't do V4, all right? I'm busy. I gotta go empty a bedpan. Okay, so V1, V2, V3, V4 look like that. V5 and V6 take on that configuration, and that negative deflection is called a septal Q wave. And you got it because the impulses went across the septum. V1, V2, V3. Notice the presence of an R wave. That upright complex is called an R wave. And you have an R wave because you have an anterior septal wall. Electricity went through it. It's a good thing. So whenever you're looking at V1, V2, V3, V4, make sure you look for an R wave because that's a good thing. If you're looking at V1, V2, V3, V4, and you notice that in V1, V2, V3, V4, you don't have an R wave. No R wave. No R wave. You say to yourself, no R wave, no anterior septal wall. Where is it? Dead. Your patient, infarcted. Or your patient, infarcting. Either infarcted or infarcting. So no R wave, no anterior septal wall. We here are infarcted. This is infarcted. Infarcting, you get ST elevation. This is infarcted. This is infarcted. Now this is infarcting. Infarcting, infarcted. Just call up some attending at 3 o'clock in the morning going, infarcted, infarcted, infarcting. Patient infarcted. right? So we lost our R wave. So you lose your R wave, ST elevation, infarcting. So in the anterior septal wall, you lose your R wave and you get ST elevation, infarcting. What are we doing here? Infarcting, infarcting. Have a good time at work. For the amount of money they pay, you should be lucky you show up, all right? All right, here we go. So whenever you're looking for injury, whenever someone is infarcting, you get ST elevation. When someone's infarcting, you get ST elevation. So in leads 2, 3, and AVF, inferior wall. In leads 1, AVL, V5 and V6, lateral wall, it will look like this. You see, you draw an imaginary line. That red line is an imaginary line, and anything that goes up should come down to it, and anything that goes down should come up to it. And so you see when you're having injury, you get ST elevation. That ST segment does not come down to the isoelectric line. So when you are infarcting, or when you're having injury, you get ST elevation. When you look at V1, V2, V3, V4, this is how you're supposed to look. And if you're infarcting, you lose your R wave. Right? You lose your R wave, ST elevation. You lose your R wave, ST elevation. So this is anterior septal wall MI, infarcting, injury. So really, when you're looking at a 12 lead to see if someone had an infarction, you look for either a fireman's hat or you look for a tombstone. That's it. That's all you look for. Near, 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 near. Or so you either look for a tombstone or a fireman's hat. That's all. People say, oh, you know how to read a 12 lead? How many brain cells you need for this? You either look for a fireman's hat or a tombstone. That's easy. And then when you see it, you go, near, near, near. So let's go. Looking at a 12 lead, always get into the habit of looking at the inferior wall first, which would be leads 2, 3, and AVF. In lead 2, 3, and AVF, lead 2, what do I have? Near, near, near. Lead 3, near, near. AVF, near. So I'm having, right, ST elevation. I'm having an inferior wall MI as evidenced by ST elevation in 2, 3, and AVF. Then I look at the lateral wall leads. High lateral wall first, 1 in AVL. Looking at lead 1, that looks all right, other than the P waves. And AVL, oh, I have some ST depression. But you know, in the light of inferior wall MI, you may see ST depression in the lateral wall leads. It's known as the reciprocal change. In the high lateral wall leads, 1 in AVL, sometimes with an inferior wall, you may see ST depression. And they say it's a reciprocal change. They say if your inferior wall is here and your lateral wall is here, and you have ST elevation here, because you have an inferior wall, MI, your lateral wall, the high lateral wall, leads 1 in AVL, will reflect that, and it gets reflected as ST depression. They say it'll go away, it should go away in 24 to 48 hours. If it doesn't, then it's ischemia. Now, I don't buy any of it. I don't buy any of this reciprocal change business. I personally think if you have ST depressions, it's ischemia. You know, because who could say after 48 hours it becomes ischemia? So for the first 48 hours, it was a reciprocal change, and then at 12:01, it's ischemia. You know what I'm saying? I don't buy it. Anyway, then I look at the rest of the lateral wall, V5 and V6, and that looks all right to me. And then when I look at lead 1, V1, V2, V3, notice that upright deflection. You have an R wave in V1, an R wave in V2, and an R wave in V3. So that's very good. But you do have some ST depressions in V1, V2, V3. So you do have a little anterior septal wall ischemia. But the big to-do here is inferior wall MI, right? Inferior, it's not interior, it's an inferior wall MI. Someone at CCU calls it an interior wall MI. It's like a name tag this big. She's a RNC, what is she? RNC, she's a CCRN, she's a CEN, she's a CNFN. I don't know what that is. I think flight nurse. But where are you flying? You're in CCU. But anyway. And then she has ACLS with a C because she's certified in ACLS. Then she has PALS or something. She has a C because she's certified in PALS or whatever. She's got like 9,000 initials after her. Her name tag's about this big. And then in the middle report, she says to me, oh, and he has a massive interior wall MI. I'm like, okay. And then people say, Gasparis, why don't you correct her? I'm not going to correct her. You correct her. She'll show up tomorrow with more initials after her name. That's why she's doing this. You ain't making her feel important. You start making her feel important, she'll take some initials off her chest. Here we go. 2, 3 in AVF. Lead 2. Near, near, near. Lead 3. Near, near, near. AVF. Near. We're having a inferior wall MI. What do I call the ST depressions I see in 1 and in AVL? For the first 24 to 48 hours, you're supposed to call it a reciprocal change. Then I look at the rest of the lateral wall, V5 and V6. I do see some ST depressions in V5 and V6, so I do have a little lateral wall ischemia, because you only see the reciprocal change in the high lateral wall. And then I look at V1, V2, V3. I'm happy, I'm happy, I'm happy, I'm happy. Why? I have an R wave. Although I'm not jumping for joy, because I do have some ST depression in V1, V2, and V3. So I do have a little anterior septal, maybe a teeny bit lateral wall ischemia, but the big to-do here is inferior wall MI. Hey, what's this one now? Look at this one. Near, near, near. Look at this, in 3. Dead tissue, dead tissue, dead tissue. Still making more, still making more. AVF, near, near, near. So we have ST elevation in 2, 3 in AVF. We're having a inferior wall MI. What do I call the ST depressions I see in 1 and in AVL? I had just a little reciprocal change. Then I look at the rest of the lateral wall, the low lateral wall. V5 and V6 have some ST depression. So I am going to call that ischemia. And then I look at V1, V2, V3. I'm happy, I'm happy, I am happy. Why? I have an R wave. Although I'm not jumping for joy, because I do have some ST depressions in V1, V2, and V3. So I do have a little anterior septal and lateral wall ischemia. But the big to-do here is inferior wall MI. Tell you, it makes you want to go into work, doesn't it? Two, 3 in AVF. Lead 2, I have some ST depression. Lead 3, I got some ST depression. AVF, I have some ST depression. Could be ischemia, but it could be a reciprocal change. Whenever you have an anterior wall MI or an anterior septal wall MI, you may see reciprocal changes in the inferior wall leads. Let's read on. Lead 1, now the lateral wall. That looks good. AVL, I'm not sure if it's elevated, because it has to be elevated more than 1 baby box. So I'm like this, look. I don't know. But then I look at V5 and V6. I got near, 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 near. So I have ST elevation, V5, V6. I'm definitely having a lateral wall MI. Then I look at V1, V2, V3. No R, no R, no R, no R, no anterior septal wall. Where is it? Dead. Your patient? Infarcting, infarcting. Why? Because you have ST elevation. So this is an anterior septal lateral wall MI. And you really can't stand there in the unit saying, oh, my patient has an anterior septal, a lateral wall MI. Someone that hit you in the face with a pie. Shorten it up. Massive anterior. That's what they call it. A massive anterior. And the ST depressions I see in 2, 3, and AVF are just a reciprocal change. Here we go. I think we have 1 or 2 more. Lead 2, that looks good. Lead 3, that's fine. AVF, great. Lead 1, absolutely good. AVL, looks weird, but it's good. V5, fireman's hat. Near, near, near. V6, ST elevation, top of a fireman's hat. So we're having a lateral wall MI. Then I look at V1, V2, V3. No R, no R, no R. No R, no anterior septal wall. Where is it? Dead. Your patient? Infarcting, infarcting. We're having an anterior septal lateral wall MI known as a massive anterior. Right? Be dramatic at work. Here we go. 2, 3 in AVF. Lead 2. Looks good to me. Lead 3, little ST depression. AVF, little ST depression. Could be ischemia, but it could be a reciprocal change. Let me read on. Lead 1, fireman's hat. Near, near, near. AVL, fireman's hat. V5, dead tissue, still making more. So we're having a lateral wall MI. ST elevations, 1, AVL, and then V5 and V6. Then when I look at V1, V2, V3, no R, no R, no R. No R, no anterior septal wall. Where is it? Dead. Your patient, infarcting. So we're having an anterior septal lateral wall MI known as a massive anterior. There'll be no living with you when you go back. Yeah. Now, when you're taking care of people with a myocardial infarction, you got to anticipate complications. The complications associated with an inferior wall MI is very different than complications associated with an anterior wall MI. So let me talk about those complications. Now, your right coronary artery supplies your inferior wall, but it also supplies other structures. It supplies your sinus node about 55% of the time. It supplies your AV node at about 90% of the time. And the right coronary artery supplies your right atrium, your right ventricle, and your mitral valve all the time. So that if you have an inferior wall MI, we have to anticipate some complications coming out of the structures of the sinus node and the AV node especially. Most common complication you will observe in a patient with an inferior wall MI is sinus bradycardia. Most common complication. And the nursing books say that the reason why you're bradycardic is because the heart's trying to protect itself. By beating slower, it'll use up less oxygen, and that's how the heart protects itself. Isn't that nice? Your heart's trying to protect itself. Hey, if it had a big concern for you, why the heck would it infarct you in the first place, you know? I mean, if you're bradycardic, it has nothing to do with your heart trying to protect itself. What do you think? You have a heart attack and all of a sudden you grow a brain in your heart and hello? Leave it to nursing books. The reason why you're bradycardic is because your sinus node is ischemic. That's why you're bradycardic. You're bradycardic because your sinus node is ischemic. And when a patient is bradycardic, they can do one of three things. They can be totally asymptomatic. They're sitting up in bed eating egg beaters and an English muffin. The heart rate was, let's say, 60, drops down to 38. The alarm goes off, you run in there, and he's eating. So what are you going to do for him? Nothing. Just keep an eye on him, that's all. Stay away from atropine. The only people you give atropine to is people whose eyeballs go behind their head. Those are the only people you give atropine. So if they're asymptomatic, keep an eye on them. Let's say you have somebody's heart rate was 60, drops down to 32. And you go in there and he's dead. So what are you going to do? Call a code. Okay. And then you may have the person whose heart rate was 58, drops down to 38. All of a sudden his alarm goes off, you're like, uh-oh. And then you notice his light goes on. So that's a very good sign that his light went on. So then you run in there, you're like, I get dizzy, I get dizzy, I get dizzy, I get dizzy, I get dizzy. It's like I'm a little lightheaded and I got ringing in my ears. You're like, so then you take his blood pressure, 120/70. Take his blood pressure in the other arm, 120/70. And that's what his blood pressure always is, 120/70. So we don't have a drop in blood pressure, but he's a little lightheaded and he's got ringing in his ears. So what are you going to do? You're going to lie him flat. Lie him flat, raise his legs, right? Put his legs up in the air. That's what you're doing. His legs, not your legs. Although if you were to lie flat on your back and put your legs up in the air, as a female nurse, that'll get his heart rate up faster than heartbeat. Really. Works every time, you know? But they're not paying you enough money to assume that position, all right? They throw you a couple of hundred, you say, I'll think about it, but not for $25, $30 an hour. I ain't doing it. Anyway, so you want to lie him flat. You're laughing. I work with some nurses that if I go up to them, I'm like, Sarah, you know, in order to keep our jobs, we have to lie flat on our back and put our legs up in the air. There'd be nurses flat on their back with their legs up in the air. You want to make a bet? I'll make a $1 million bet. Anyway, so lying flat, raise his legs. Stay away from atropine. You would not give him atropine. By lying him flat, raising his legs, you're putting more blood into the right atrium. And by stretching the right atrium, the right atrial tissue releases a chemical which increases your heart rate. Stay away from atropine. When people are sleeping, they go bradycardic. Let them sleep. Some nurses always got to wake up people. Not us night people. We don't wake up nobody. But every once in a while, they got some day babe that comes down on the night shift, right? Not for nothing, I'd rather work short staff than have her help, okay, between me and you, because they annoy me. You know, if you work the night shift, you know, you're up all day. You're up all day, you're cooking, you're doing laundry, you're cleaning, you go grocery shopping, you prepare dinner, you get the kids in pajamas, and then you go to work. I'm tired. So I'm tired. Then that day, babe, she knew she was doing that night shift. Like 6 months ago, she had that assignment. She slept all day. Everyone in the family left the house to let mommy sleep. She's going to do a night shift. So she's all well rested. She comes in, her hair's all curled and everything. She comes in, she's all happy. She's like, hi, hi. Shut up. And then after she gets the report, she jumps up, she's cleaning, she's stocking. You know, she's showing us night people what it is we should be doing, you know? But then about 3 o'clock in the morning, she don't look good. She's all really pale, pasty. She got blankets. Yeah. Meanwhile, us night people, we could sleep sitting up. I mean, I'm asleep. I'm sound asleep. I'm sitting up in front of a child. I got a pen in my hand, but I'm sleeping. I'm just staying like that just in case supervisor comes around. You know what I'm saying? But anyway, every once in a while, when you are graced by a day babe on the night shift, and the alarm goes off, and the guy goes bradycardic. Heart rate was 58, drops down to 38, all right? I'm like right in front of his room. I'm looking. His chest is going up and down. I'm leaving him alone, right? Ain't going to go in there, check his leads or anything. He's sleeping. She wants to go running in there. No, don't go in there. Don't. She's like, but. I'm like, but what? Don't go in there, break your legs. But what? What's the worst thing that's going to happen? It's going to drop dead? Hey, most people when they die, they want to die in their sleep anyway. Leave them alone. Let them die, and then we'll go save them, right? Stand in my room. That's it. But anyway, they were looking to save a day. Oh. And I have night people here, right? Where are you? All right. Oh, very good. All right. I ain't asking where the day babes are. Never mind. Hey. You're a day babe? You don't work at CCU, do you? Oh, no, please. Okay. Please, get me calipers. What's this P? What's the PQ? What's the QRS? What's the P wave? What's this? What's that? It's like, shut up! All right, so anyway, if people are sleeping, let them sleep, okay? Now, the problem with the AV node, right? The problem with the AV node is complete heart block, third-degree heart block, or AV dissociation. Call it whatever you want. Now, to me, this is the same arrhythmia, but really it's not. I'm putting a lecture together on this now. It's like, oh, how stupid am I? I've been a nurse for almost 40 years, and I always thought it was the same thing, and then I'm reading. It's not. But anyway, right, didn't you think it was the same thing? I mean, MICU nurses, I'm sure you knew it was totally different arrhythmias. But MICU people, didn't you think they're the same thing? I always thought that complete heart block, third-degree heart block, AV dissociation, I figured it was the same thing, some kind of disconnection between the atrium and the ventricle, right? It is a disconnection, but they're 3 completely different arrhythmias. I was like, wow, I never knew that. But I can't tell you much more because I didn't finish the seminar. All right, but anyway, I'm putting it together now. I did learn, like a little quick clue, is a quick differentiation between third degree and AV dissociation. There's a complete dissociation between the ventricle and the atrium, but the quick way to differentiate is complete heart block has more P's in it, in the strip, than AV dissociation. But that's why I tell you, because I didn't put the lecture together all the way. Anyway, but call whatever you want. I always thought it was the same thing. But if you have AV dissociation, complete heart block, third-degree heart block, and you have an inferior wall MI, a pacemaker must be inserted, no ifs, no ands, no buts. No matter what the heart rate is, a pacer has to be inserted. Had a young guy. He was in AV dissociation. I didn't notice it because the alarm never went off and I never looked up. Anyway, it looked good. Every time I looked up, it looked good to me. Then my friends say, Gasparis, he's in and out of junctional. I'm like, junctional? I'm like, no, he's not. They're like, yeah. It's like, oh, I'm like, what's this junction? He's in and out of upper junctional. I'm like, where'd you get this from? What are you doing, a rotation in CCU? So we got this big, long strip. I'm like, oh, it's normal sign. It's like rate 70, sometimes it's 80. And then all of a sudden, I see a P wave going into the QRS. Then, the next beat, I see the P wave after the QRS. And then it looked like pretty good to me. Well, he was in AV dissociation. It's just that somebody high up in the AV node was kicking in, and that's why he had like a good heart rate. And so really, you couldn't tell because his heart rate was good. So, but he was in AV dissociation. She thought it was junctional because she saw the P wave after the QRS, so she thought it was junctional. But if it was junctional, the P wave would be inverted, but it was going up, so then that's why it was AV dissociation. All right, but anyway. So I call the attending. I say, listen, you're another 42-year-old with an inferior wall MI. I said he's in AV dissociation. So you got to come in to put a pacer, all right? I have a 5 French, a 7 French. I'll come to your house. I'll do whatever. You have to put it in. So then he says to me, well, what's his heart rate? Now, I know if I told him 70 or 80, I know he would never come in. He ain't never coming in. He'll come in at 7, but he ain't coming in the middle of the night. So when he said, what's his heart rate? I said, 20. It's 20, 20, 20. It's like, I'll be right there. So he comes in, runs in, right, where's the strip? Give him a strip. You have a strip? Let me see a strip. So I give him the strip. Right, he's looking. Then he's like, this is 80. This is 80. You told me it was 20. I said 20, 20, 20, 20. That comes to 80. It comes to 80, might put a pacer, all right? So then I got written up front, ethical behavior, because I lied. And then, so then they put a pacer in, and then at 6 o'clock in the morning, this 42-year-old was 100% pacing, like 100%, and we even turned down the pace a little bit just to see what the underlying rhythm was, but there wasn't any, we didn't turn it down to like 10, but, so there was nothing underlying, all right? So if they put the pacemaker in, he would have been dead, all right? So write me up now, all right? Hello, Brenda, you want to write me up now? I saved a life. Anyway, the problem at the right atrium and the right ventricle is the right ventricular infarct. 30% of people with an inferior wall MI infarct their right ventricle, right? 30% infarct their right ventricle. And now that 30%, 10% can go into congestive heart failure, right-sided failure. And out of that, I think it's 1% goes into cardiogenic shock, right-sided failure. And the problem with the mitral valve is mitral insufficiency. Now, when you're taking care of someone with an anterior wall MI, you know that your anterior septal wall is supplied by the left anterior descending. And the left anterior descending supplies the bundle of His and the bundle branches and the ventricular septum. The problem that comes out of the bundle of His is a Mobitz 2. You don't worry about a Mobitz 1. Mobitz 1 comes out of the AV node. You don't worry about it. Mobitz 1, that's where you have a progressive prolongation of the PR interval, and then you got a P with no QRS. You don't worry about that. It'll go away on its own. Mobitz 2, though, you're talking about the bundle of His having a problem, and a Mobitz 2 is bad. That's where you have a constant PR interval, and then also you got P's with no QRSs. And then the other thing you got to worry about is a bundle branch block, a right bundle branch block. Should your patient with an anterior septal wall MI develop either a Mobitz 2 or a right bundle branch block, the mortality rate is 94%. Put a pacemaker in, drops down to 14%. Good save. And the problem that comes out of the ventricular septum is a ventricular septal defect. See, now with a right bundle branch block, the only lead that you could read a right bundle in is V1, is the precordial leads, V1, V2. Can't read it in lead 2. Lead 2 does not change when you have a right bundle branch block. So to be working in CCU where everybody's in lead 2 is the most stupidest thing in the world. Because if someone develops a right bundle branch block, they have a 94% mortality rate. But you wouldn't know it because you have them in lead 2, and lead 2 doesn't change when you have a right bundle branch block. When you talk about cardiac trauma, you get ST elevation. When you have cardiac trauma, you can either have a myocardial contusion or you can have pericarditis. If you have a choice, I'd rather get pericarditis. Both of them, though, you get ST elevation. Myocardial contusion, you get ST elevation in those leads looking at the boo-boo. Pericarditis, you get ST elevation in all your leads. And then the other difference is the way the ST is. When people have myocardial contusion, when you look at the faces it makes, like pericarditis, you get like a happy face. Oh, I have a little pericarditis. Whereas, oh, shoot, I've got me a myocardial contusion. Get like a sad face. Just be careful, people with pericarditis, you got to watch them for cardiac tamponade, right? You got to watch them for cardiac tamponade. They might give you one pacemaker strip. If they do, it's either that one, where that would be failure to capture, or it could be this one, which would be failure to sense. So that's easy. Either failure to capture or failure to sense. And now shock. Not too many questions on shock. You would think there would be like 9 million questions on cardiogenic shock, but there isn't. There's only one scenario on cardiogenic shock. Matter of fact, most of the questions on shock are on septic shock. Now, when you read your core curriculum, it can be a little confusing. They have charts. I mean, I can figure out this chart. I don't have a problem. Although I do get a headache reading that chart. I'm like, where are you supposed to go? Left, right, up, down, you know? So that's why I explain it my way. Whenever you're in shock, no matter what kind of shock you're in, initially you go into what's called the compensatory stage of shock. Then you go into what's called the progressive stage of shock. And then you go into what's called the refractory stage of shock. Now, we don't talk about the refractory stage of shock because that means no matter what we do, you're still going to die. So why talk about it? So we talk about the compensatory stage. When you're in the compensatory stage of shock, what happens is you have a decrease in cardiac output for whatever the reason is. Maybe you're in septic shock where you pool 50% of your blood in your capillary bed. Maybe you're in cardiogenic shock where you infarcted your left ventricle and lost 40% of the functioning of that left ventricle. Or maybe you're in hypovolemic shock, or maybe you're in hemorrhagic shock. Whatever the reason is, whenever there's a decrease in cardiac output, that will stimulate your sympathetic nervous system to release adrenaline. And adrenaline will increase your heart rate, it increases your blood pressure, it makes you release ADH so your kidneys hold on to water, and you get vasoconstriction. But you can only vasoconstrict for a certain amount of time, because when you vasoconstrict too long, you then build up in a metabolic acidosis. In building up with a metabolic acidosis, you're now going to vasodilate. Once you vasodilate, you become hypotensive, and it's a bad thing. That's the overview. When you talk about particular shocks, hypovolemic shock, some of the signs of hypovolemic shock, ACN in their core curriculum stresses people in the compensatory stage are anxious and irritable, and in the progressive stage they're obtunded and stuporous. Now, to me, these are stupid signs to look for. If you work in the hospital, half the people in the hospital, both patients and staff, are pretty much anxious and irritable, and the other half, both patients and staff, are pretty much obtunded and stuporous. So what are you going to look for these signs for, all right? Really, to look for the compensatory sign of shock is really orthostatic blood pressures. But they never do that anymore. We always did it. Years, 30, 40 years ago, that's all we did, is orthostatic blood pressures. They don't do that no more. I don't know why. You know, I had a group of nursing students, and they looked like the nurse nymphets. That's what I call them, the nurse nymphets. They had the uniforms rolled all so high, it ended like here. I'm like, why wear anything? You know what I'm saying? And then they had these long nails with the Swarovski crystals on it and cleavage. I'm like, oh, hey, what's going on over here? Anyway, I was trying to explain to them that there's other things to do with the stethoscope besides draping it around their breasts. So I'm explaining to them how to do orthostatic pressures. I said, when you do an orthostatic pressure, first you do it lying, then you do sitting. Lying, sitting, lying, sitting, lying, sitting. Because sometimes they do it backwards. They do it sitting and then lie the patient down, don't work. So I said, repeat it after me. First we do it lying, then we do it sitting. Lying, sitting, lying. All right, so they did it 100 times. So then we go to clinical. I give them their assignments, and then I'm walking down the hall making sure nobody's killing anybody. And I'm walking, and all of a sudden I see my nurse is in bed with the patient. Now, beds really aren't big enough to put two grown-ups in, you know, but she's lying in bed with him. Nice-looking man. 44-year-old rule-out GI bleed. Nice-looking guy. Anyway, she's lying in bed with him. She got the cuff on his arm. She got the stethoscope in her ear. And she's taking her blood pressure. They're lying. They're both lying in bed. Taking the pressure, lying. All right? Then after she takes it lying, right? Then she sets them both up, and they're touching cheek to cheek. I don't know what cheeks are touching. Now taking it sitting, and I'm watching this. And then after that, I'm like, get over here. I'm like, what are you doing? And she was a real snip, but I like that in a student. She said, you said to do it lying, sitting, lying, sitting, lying, sitting. I said, I did say lying and sitting. The patient, not you. What did you say when you crawled into bed with him? She said, well, you know, when I was lying down next to him, he turned to me and said, no one has ever taken this pressure like this before. I'm like, you know, that should have been a clue. She's probably your nurse manager. Nah, it's probably higher up. It's probably assistant director of nursing or something. All right, so anyway, you're supposed to look for anxious and irritable, obtunded and stuporous. I particularly don't care for that. Hypovolemic shock in the compensatory stage because of the adrenaline release, you're tachycardic, cool, pale, decreased urinary output. And then when you go into the progressive stage, you're vasodilated, you're now hypotensive, decreased CVP, wedge, cardiac output, and you have an increase in SVR. The treatment for hypovolemic shock is fluids, crystalloids, colloids. Crystalloids, normal saline is a good crystalloid, normal saline, Ringer's lactate. And then colloids would be your salt poor albumin, right, 25% albumin or 5% albumin. You know, you give that little baby bottle of albumin that's only like 50 cc's. Do you know that pulls from the cell 250 cc's of fluid? So what you wind up doing is increasing the intravascular volume by 300 cc's. So whenever I hang that, it never drips. You ever notice that? You hang it. I have it like hitting the ceiling, it's slowly dripping. You know? I can't tell if it's dripping. I don't think it's dripping. Then I bring it down. I'm like, it didn't drip. Then I squeeze the chamber. Figure that'll work. Then it fills up. So then I go like this, squeeze everything back down. Then I go like this. There's little bubbles in it. So now I can't see if it's dripping. Then I'm flicking. And I'm like, the heck with this. I'm getting a needle. I'm gonna vent it. Really, you don't vent nothing. You put the needle in, you didn't make a vent. A vent only happens when the needle is up in the air. But that needle's never long enough, it's always in the fluid. That's why when we put the needle in, some fluid comes out. Maybe 1 or 2 drops. That's all. I always wonder why the whole bottle don't come out. But just 1 or 2 drops. It's no big deal. It's like this I got. No, it's sterile. It's sterile. All right. And then you're hanging up, and then someone says, you want to go on first break? You're like, I'm not, I'll go later. Then you look, and it all ran in. Bring it down, take the needle, get rid of the needle, shut it off. So now, this is scary, because you just gave him 50 cc's, which pulls from the cell 250 cc's. So you just increased his intravascular volume by 300 cc's. So you're like, hey, how you doing? You all right? You feel good. You feel all right, right? You feel all right? Feel good, right? You're like, right? Take it. You feel all right, right? Then you're like, you know, I'm starving. You know, maybe I will go on first break. I'm out of here. All right, fresh frozen plasma and red blood cells. Okay, good. Cardiogenic shock. Okay, always a question on cardiogenic shock. The person on the exam that goes into cardiogenic shock is somebody that had an anterior septal wall MI and infarcted his left ventricle, lost 40% of its function. Then he goes into cardiogenic shock, and then you put him on an intra-aortic balloon pump. So a lot of etiology is a cardiogenic shock, but on the exam it's a person with a myocardial infarction. When people go into cardiogenic shock, initially you observe left-sided heart failure. They'll become tachypnic, and they have an increase in heart rate, and you'll hear an S3 and an S4, and the blood pressure will begin to drop, and then the pressure continues over to the lungs, and you'll get pulmonary edema, and you'll hear rales, and then it continues over to the right side of the heart, and then you'll get neck vein distension. So cardiogenic shock is a progressive congestive heart failure that starts on the left side of the heart through the pulmonary vasculature and returns to the right side of the heart. The treatment for cardiogenic shock is early reperfusion, TCA, CABG, intra-aortic balloon pump, inotropic drugs. But on the exam, the treatment for this person who goes into cardiogenic shock because of a myocardial infarction, we are going to put him on an intra-aortic balloon pump. Now, if you don't work with intra-aortic balloon pumps, they're not, you know, it's not a scary thing. All it is a catheter, and that catheter is in your aorta, and on that catheter you have a balloon. And on that catheter is a balloon, and sitting in your aorta, and that balloon will inflate and deflate, right? So the catheter will inflate, deflate, inflate, deflate, inflate, and the patient's chest shouldn't be doing this because that would maybe mean like an overinflation, but inflate, deflate. Now common sense would dictate that you wouldn't want this balloon to inflate in the aorta when the blood is coming out of the left ventricle. Because if you're coming out of the left ventricle and there's a balloon there, it don't make for a good cardiac output. Because when you come out of the left ventricle and there's a big balloon there, you would go splat. And there would go your cardiac output. So common sense would dictate that you would want this balloon to deflate when the heart's deflating, when the heart's in systole. When the heart's in systole or the heart's deflating, you want the balloon to deflate. Because when the balloon deflates and my heart deflates and the blood is coming out of the left ventricle, and there used to be a balloon there, now it's not there no more, it's like free sailing ahead. It's like when the balloon deflates, it causes like a vacuum. I get sucked out of the left ventricle. So it really decreases the afterload. It really decreases the amount of resistance met by the left ventricle during systole. It improves cardiac output because, again, it's clear sailing ahead. And then when that balloon deflates, it makes like a vacuum and you get sucked out of the left ventricle. So, and then when the balloon inflates, right, the valve closes, the balloon inflates, and it displaces blood. Half the blood goes down to your kidneys, and the other half of blood goes into your coronary blood vessels to supply your heart muscle with blood during diastole when it usually gets its blood supply. So we improve myocardial oxygenation. So that the intra-aortic balloon pump decreases afterload, decreases myocardial O2 demand, will increase the coronary perfusion during diastole, and it does improve the cardiac output up to like 15%. The uses of intra-aortic balloon pump, there are many, but on the exam, you're doing it to support an acute MI with shock. Contraindications, aortic insufficiency. If you have an aortic valve that just don't close good, last thing you need is a balloon underneath it. Because if I have an aortic valve that don't close good, and I have a balloon underneath that inflates, it's going to displace that blood up through the incompetently closed aortic valve into my left ventricle. So you need a good aortic valve. And then peripheral vascular disease sometimes is contraindications for an intra-aortic balloon pump. Complications, other ones, ischemia of the limb, dissection of the aorta if it's overinflated, and infection. Don't sit people up, right? Keep them low, 15 degrees, no higher. If you sit them all the way up, you'll kink the catheter and the balloon will stay inflated. Assess the pulses, monitor bleeding. And remember that the balloon will inflate when the heart's inflating, and the balloon will deflate when the heart's deflating. So the balloon and the heart do the same thing. Balloon inflates when the heart's inflating. Balloon deflates when the heart's deflating. That's easy to remember. And then the last one is septic shock. Leading cause of death in ICUs, carries a pretty high mortality rate, anywhere from 40 to 60%, and really some books say 95%. It's usually the result of gram-negative bacteria, although you can get it from gram-positive, but it's usually gram-negative, whether it be E. coli, Klebsiella, Pseudomonas, Proteus, Serratia marcescens. Other things about septic shock is how it all happens. You have gram-negative bacteria, and that gram-negative bacteria may release an endotoxin. And I say may because it may not. If your gram-negative bacteria doesn't release endotoxins, then you're not going to go into septic shock. Because let's say me and you in the hospital. You're in one bed, I'm in the other. I say to you, hey, how you doing? You say, I'm not doing good. I'm like, why, what do you have? You say, I have germs in my blood. I'm like, so do I. What kind do you have? You say, E. coli. I'm like, me too. So we're hanging out in the room, and we both have sepsis, right? We both have sepsis. All of a sudden, 12 midnight, I spike a temp of 103. People are running around, they're doing blood cultures, they put me on a cooling blanket, everyone's going crazy. I am now septic. You still have sepsis. Why? Because my gram-negative bacteria released an endotoxin and yours didn't. So once your gram-negative bacteria releases an endotoxin, it causes the release of some very horrible things. Some very horrible vasoactive substances, of which you don't have to know the names, but it causes your body to release cytokinins, bradykinins, interleukins, histamines, serotonins. And what these horrible things do is cause massive vasodilation. The problem in septic shock, you pool 50% of your blood in your capillary beds. 50% of your blood's in your capillary beds. But you know, in the beginning, though, you're not symptomatic. In the warm stage, you would think you'd be hypotensive with 50% of your blood stuck in your capillary beds. But no, it's not true. In the warm stage, you look good. You see, the endotoxin works on your heart muscle and makes your heart beat like it never beated before. You have a cardiac output anywhere from 9, 10, 11, 12 liters a minute. Ordinarily, you're like 4, 5, maybe 6. Here, it doubles your cardiac output. The endotoxins work on your heart, make your heart beat like it never beat it before. You are perfusing body parts you never knew you had. The endotoxins work on your brain, make it confused. The endotoxins increase your cardiac output. They increase your respiratory rate. Why? Because the endotoxins work on your medulla, increase your respiratory rate. So you wind up having the best EBG you ever had in your life. You wind up having a great blood pressure. You wind up looking good. You got a good urinary output. Why? Because you pooled half your blood in your capillary beds. Your kidneys are full of capillary beds. Your Bowman's capsules are having a ball. They never filtered so much blood in their entire life. So that's why you got a good urinary output. So that's why when people in the warm stage of septic shock, everyone thinks they're doing good. That's why when you give a report, don't you say, oh, she looks good. Oh, she looks so good. Oh, she looks good. She looks good. She got a glow. She looks good. And then you come back the next day and she dropped dead. You're like, hey, what happened? She was looking so good. Why? She was in a warm stage of septic shock. People look good in the warm stage of septic shock. But you can only stay in the warm stage for a certain amount of time, anywhere from a half hour to 72 hours. After that, the endotoxins fizzle away. And now your heart goes back beating the way it usually beats. And because half your blood's stuck in your capillary beds, you're hypotensive. You become stuporous, obtunded. You got a decrease in cardiac output, decrease in urinary output, bad ABGs, you're in a metabolic acidosis, and you're hypotensive. And once hypotension sets in with septic shock, you got like a 90-95% mortality rate. Because what's going to happen now is you're going to develop ARDS, acute tube necrosis. We say multi-system organ failure, AACN says multi-organ dysfunction syndrome, MODS, and DIC. So, the treatment of septic shock, 1 ton of fluids. See, if I overhydrate you in the warm stage, when you do go into the cold stage, you'll never go hypotensive. You'll never go hypotensive. And because you don't go hypotensive, you're not going to die. So the treatment, of course, I'm going to give you antibiotics. But the real treatment that saves your life is I got to give you a ton of fluids, so that when you do go into the cold stage, you don't become hypotensive. And if you're not hypotensive, you're not going to die. Let's do some questions. Watch how smart you are. There'll be no living with you. Which of the following pressures are within the normal limits? Well, you know C isn't right because your wedge can never be higher than your PAD. So you would say D, right? 24/14 and the wedge at 12. That's good because your wedge can never be higher than your PAD. See, B, having a PAD at 20, that's a little too high. Which of the following would cause an elevated pulmonary artery pressure and a normal wedge? And you would say pulmonary hypertension. That's what you would say. Good. A large V wave appears on the pulmonary capillary wedge pressure tracing of a patient with an inferior wall MI. To see a large V wave when you're doing a wedge is indicative of mitral regurgitation or mitral insufficiency. Good. And where do you find that V wave when you put air into the balloon? You find the V wave after the T wave. You find the A wave after the QRS. Learning has occurred. ST elevations in the absence of an R wave. And V1, V2, V3 would be indicative of an anterior septal wall MI. Good. Which of the following hemodynamic parameters would indicate left ventricular failure in someone with COPD? Well, if you had COPD, it can't be B, because you would never have a wedge of 6 with a COPD. COPDs always have some component of right-sided failure. So it has to be, well, I think it has to be either C or D, right? And then if you have COPD, you can't have a normal pulmonary artery pressure, right? At least the top number can't be normal. So it has to be D. Good. The reciprocal changes that occur with an inferior wall MI and are seen are ST depression in leads 1 and AVL. Good. Which of the following complications is most likely to occur with an inferior wall MI? And you would say a Mobitz 1. Because PAT, Right bundle branch block and cardiogenic shock are seen in an anterior septal wall MI. Patient has inferior wall MI, also develops a right ventricular infarct, and he goes into right ventricular failure. Which data obtained would correlate with this patient's condition? Well, if you're in right-sided failure, you have to have a high CVP. So that rules out B. And then if it's all right-sided stuff, you got to have a normal wedge. Right? Your wedge has to be normal. So now it's either A or C. And then if it's all right-sided failure, you shouldn't have a pulmonary artery pressure systolic number of 54. No. So it has to be A. Treatment modality for a patient with right ventricular failure from an inferior wall MI would be normal saline. Anyone with right-sided failure, flood them with fluids. You want to increase the preload. You want to increase the preload because by increasing the preload, I increase the stretch. And by increasing the stress on the right side of the heart, I could be guaranteed that more blood's going to go over to the left side of the heart. Which of the following groups of hemodynamic data reflects cardiogenic shock as opposed to hypovolemic shock? Well, if it's cardiogenic shock, it can't be A because you wouldn't have a normal wedge of 12, right? So now it's B, C, or D. And then if someone's in cardiogenic shock, they're going to be in pulmonary edema. So you can't have a normal pulmonary artery pressure. So it can't be C. So now it's either B or D. But it can't be B because your wedge can never be higher than your PAD. So you have a wedge of 22 and a PAD of 20. It can't happen. Has to be D. And you might say, well, 96 over 56, that ain't too bad. Well, no, unless he came in with 200 over, 110, yeah, then now he is bad. Clinical manifestations of cardiogenic shock following an anterior wall MI will include all the following except anterior wall MI, you go into left-sided failure, which then can progress. Well, anterior wall, he's in cardiogenic shock. So you're going from left-sided failure into right-sided failure. So you will get distended neck veins. You would get rales and pulmonary congestion. You're definitely going to get an S3. You're supposed to get a high CVP reading because that would mean right-sided failure. Unloading therapy by nitroprusside is beneficial because it enhances the ventricular emptying, yes. Diminishes peripheral vascular resistance or afterload, yes. Relieves pulmonary congestion by promoting venous pooling of blood. Absolutely true. So the answer is all the above. Which of the following is an expected outcome from the intra-aortic balloon pump? Well, you don't want to decrease the blood pressure, and you don't want to increase the wedge because he's in failure, so his wedge is high already. So you have to say increase cardiac output. To be operating correctly, the intra-aortic balloon pump, it's time to work on which of the following manners. And you would say inflate during diastole. In other words, inflate when the heart's inflating. And deflate during systole. In other words, deflate when the heart's deflating. So the balloon and the heart should be doing the same thing. Absolute contraindications to the intra-aortic balloon pump would include aortic insufficiency, because you need an aortic valve that closes good, because the balloon sits right under it. All post-op cardiac surgery patients, they all get pericarditis, because you usually have to cut the sac. Which of the following kinds of shock is characterized by an increase in venous capacitance and pooling? And you would say septic shock, also known as distributive shock. AACN likes to call it distributive shock. And you pool 50%, at least 50% of your blood in your capillary beds. So I guess that's why they call it distributive shock. The early stages of septic shock. Early stages. Well, you don't get any vasoconstriction in the early stage. So it has to be D. Early stage of septic shock, increase in cardiac output, and a decreased vascular resistance because of the vasodilation that occurs. Signs of hyperventilation. diminished sensorium, and an increase in cardiac output are seen in which forms of shock? And you would say septic or distributive shock, right? Patient admitted to ICU in the early stages of septic shock presents with, well, it's not A because you got a really good pulse, right? Not B because you got a really good urinary output. It has to be C, warm, flush skin. You do get an increase in respiratory rate, but you don't get any pulmonary congestion. So early stages of septic shock, you look good. You look good. Placement of MCL1, the positive electrode, fourth intercostal space, right sternal border, and then you put the negative electrode usually below the clavicle on the left side, middle of the clavicle. And the reason why you use MCL1 is to differentiate ectopy from aberrancy. So when you put MCL1, you're putting it really right over here, the positive sticky. When you do V1, you put the positive sticky over here. The most serious EKG finding associated with an anterior wall MI is right bundle branch block and a Mobitz 2. 94% mortality rate unless a pacemaker is inserted. Hemodynamic parameter that clinically measures afterload is SVR, systemic vascular resistance. Patient with a blood pressure, 200 over 142. Malignant hypertension, because it has to be a diastolic greater than 140. Good, good, good. And when you have IHSS or HOCM or HCM, you don't give what? DIDs, right? You don't give any nitrates, no morphine, nothing that vasodilates, or nothing that would improve the myocardial contractility. Well, learning has occurred. Now, I think we're going to be eating lunch. That's what we do. We're going to be eating lunch, and then when you come back, we got the last section, which is pulmonary. So, please enjoy your lunch, all right? Please enjoy your lunch.